This is trial. You can see 18th. Length is 45. You can do it. So this is cage guide for cage insertion. This is early cage. 45 length, 18th, and 6-degree lordosis cage. So we can put a cage under endoscopic control. This part, I call it posterior orthogonal maneuver. Line cage anteriorly and posteriorly. But you can see the exiting and transversing lobe root. There is no lobe root damage. And surgical view is very clear. And also after this job, you can put bone particles into this dead space. So next case is high BMI patient, very obese patient. But I use the early cage, 18th, 45, high 10, and 6-degree lordosis. And this is a 63-year female patient. I use the cage, early cage, 19th, 45, and high 10, lordosis is 9 degree. So we analyzed 22 cases, and the post-operative ODI VAS was good, and radiologic outcomes were good. Advantages of XTLIP is like this: direct central contralateral decompression is possible. Even if in obese patient, we can do it, and we can get a better coronary site balance, and maybe probably high fusion rate, but the low substitution rate, but still following period is not enough, so you don't know. Less multipitous muscle damage, maybe. Okay, so we can see the disc preparation. We can avoid vital organ injury. And also this procedure is a spine surgeon friendly procedure. So complications may be same as TLIP surgery, but technically demanding procedure, and we have to always worry about dural injury. But also, almost all endoscopic spine procedure, we have a significant individual learning curve. So tips for proper procedure: at least we need to unilateral sweep to osteotomy, sometimes sweep 3 osteotomy for coronary size balance and for reduction. And transverse line of large cage is important. We have to follow this PILL mismatch, less than 9 degree, SBA 5 cm, PT less than 25 degree. We cannot follow this rule always, but we have to try to follow this rule. So relative control indications. Some brave Korean doctors tried 2-3 level, but I don't recommend about 2-3 level. Preoperative check, and LKL is less than 15 millimeter. I don't recommend. You can try, but I don't recommend. Multiple levels, 3 and 4 levels, we can do it, but it takes too long time. I don't want a long operation time. You can do it, but I don't recommend. I recommend just 1 level, 2 level. If you are trying to do 4 level, 5 level, just to do the open surgery, because I'm old. I don't like that kind of long operation time. So, and one more important thing is if you need the lordosis correction more than 15 degrees, forget about endoscopic surgery. Okay. We need to correct 15 degrees more. We have to do open surgery. At least we need more than SWEPS 3 osteotomy. We have to decompress completely, and we have to manage about the lordosis correction like that. Endoscopic surgery, we can do it, but I don't recommend. Why endoscopic surgery? So present, I started this operation 2019, December, and in Korea right now over 1,000 cases we are doing, and also they reported articles, and we have a good result. So it's possible mission. Okay, we can use a large early cage under endoscopic control. Also, this endoscopic surgery is ERAS factors. Okay. Sometimes we can do awakened anesthesia, but I don't recommend infusion surgery in awakened anesthesia. So first, EXTLIP article was published 2021. So conclusion, nobody can deny bigger will be better, okay? But we need further long-term studies. Okay. Thank you very much for your attention.
Thank you, Dr. Jin, for your excellent presentation. Now I want to invite the next speaker, Dr. Elmar Jose Mikeda, to his presentation. The topic will be endoscopic management of symptomatic Bartholdi syndrome.
All right, good morning, everyone. I'm so happy to be here in Bukhara, my first time. Assalamu alaikum. I'll be talking about the anterior transcorporeal tunnel approach through an endoscope. I will go direct to my case. Patient has been suffering from nape pain. So I think this is arthritis of 1 year duration, on and off. No medication, no consultation done. But 4 months prior to admission, the patient accidentally slipped and fell on her back. There was nothing. A symptomatic patient went on with her work. 3 months prior to admission, the patient experienced episodes of intermittent nape pain, radiating down to the left arm to the first 3 digits. This was characterized as electric shock-like, which was noted to be 5/10 and relieved at rest. Patient also developed whole back pain from the neck up to the leg, even up to the toes sometimes. Intensity of 8/10 pain score. There was some medication intake, but with minimal relief. The patient also complained of difficulty of ambulation, and she was dragging her left leg, but with no assistance. So patient doesn't require assistance. 2 months prior to admission, the patient experienced progressive left-sided numbness and bilateral lower extremity weakness, unable to ambulate, noted inability to hold objects. So whenever she eats or drinks, he cannot hold with her left hand. The patient sought consult and was subsequently admitted for a consideration of a stroke. Can you believe it? So the patient was initially admitted with a consideration of stroke because of the weakness. Stroke was subsequently ruled out, and she was managed as a case of hypertensive urgency because the BP then was 200/100, and sciatica on the left was also given as a diagnosis. The patient was discharged with pain meds, and she was advised MRI. I will show you the MRI. So you can see sorry. So that's the MRI of our patient. You can see a C4-5 large disc herniation with the compression of the myelin and edema of the cord. And you can see it's around 2.1 millimeter distance in the midline. And that's the amount of disc that we have in the axial cut. Further moving on, 1 month prior to admission, the patient had progressive numbness and weakness of the left. The patient sought consult and was advised ACDF. Patient opted for rehab. 2 weeks prior to admission, recurrence of the whole back pain, still managed with rest. with now radiating pain and tingling sensations on both arms and difficulty of ambulating. So patient is now unable to ambulate at this point. And then the persistence of symptoms prompted follow-up and consult, and offered endoscopic decompression, and she was admitted on the same day. Here is her neurologic examination. You can see that the hand grip is very poor. On the left, it's only 2/5. And there is a variable minimal discrepancy in the sensory. But as you all know, any compression of the spinal cord will give us an upper motor neuron deficit. So we have a positive Hoffman and a bilateral Babinski. And there's bowel and voiding difficulty. So we did a family conference. All the discussions were for surgery. ACDF was discussed. This can possibly manage the issue of the lordosis. If you put an anterior cage, then you can correct the lordosis. However, the patient is very poor, coming from the islands. So they cannot afford the implant. We also discussed anterior transdiscal. So there was no implant cost, no fusion, and no issue about adjacent segment disease. However, it may cause subsidence. And then the anterior transcorporeal approach endoscopically, so no implant cost, but may cause vertebral body fracture. Finally agreed with an anterior transcorporeal approach. So this is the patient's positioning. Just neutral neck with slight hyperextension. And the approach is towards the midline of the disc. You can take note of the red line. That's the needle point. Then we can see here the reaming. From the midline, you push the tracheo-esophageal junction, and then you can check the carotid sheath by its pulsation. So you can do reaming. And it's very important to note that this here is the nasogastric tube that I always use for these procedures to know where your esophagus is located. The reaming is done to create transcorporeal tunnel to save bone graft because you can take the plug. It's faster and safer than drilling. Its slight change of direction is possible. And the endpoint of the posterior disc is placement at the posterior disc and end plate. So you can see here the bone plug that we were able to remove. That's the anterior body of C5. Drilling to get more space. So still we have the anterior longitudinal, the annulus of the disc. More drilling was done, but very, very small field. And finally, it's very clear. You can now reach the disc level of this C4-5. Another view of this C-arm, you can actually go directly with your forceps, your cautery, and then you can check the amount or the distance with your right angle dissector. And this is how much you can take for the disc. Another visualization. So clearing more time The end point will be clearing so much of the disc and the annulus that you can now see pulsation in the dura. I don't know if you can see it clearly, but there was pulsation there. So it's a very straightforward procedure and a very safe procedure. You can now check with your right angle dissector the cranial end, the lateral extent of your tunnel, caudal end, and the medial wall. So we have the preoperative and postoperative images. You can see the tunnel there. And you can see the incomplete tunnel. That is because I have placed the plug there. And you can see the post-op axial MRI, the reconstructed CT. So you can see the anterior part, the posterior tunnel, and then the actual tunnel with the bone plug there. In X-ray, it's also evident. You can see the hole or the anterior tunnel. Post-operatively, day 1, there's improvement of the right side, almost normal, with no more sensory deficits. The hand grip, you can check that it's from 2/5 on the left. It improved to 3+/5. Patient was discharged on day 3 on rehab at home, only paracetamol for pain meds. The status of patient 2 weeks post-op, ambulating freely except when going up and down stairs, able to hold utensils when eating, and the hand grip is 5/5. This is the modified Japanese Orthopedic Association scoring system. The red is the preoperative and the green box is in the post-operative side. You can see that the patient has improved a lot within 2 weeks. This is the algorithm that we find in Yeoman, the book, the Bible of neurosurgery training programs. Then I wanted to give a challenge and take-home message that the usefulness of endoscopic surgical techniques and approaches must be included in the treatment algorithm of these pathologies. We need to do more, learn more, publish more, teach more, and be the wind of change in the paradigm of maintaining spine health in the world. Thank you very much. I'd like to invite everyone for the ASEAN Mist in Da Nang, Vietnam.
Thank you very much for your excellent speech. I think there was a mistake about the topic and the speech, but no problem for us. Okay. Thank you.
Okay, thank you very much.
So we are taking the questions after speech, or okay, we're going on. Sorry? During coffee. Okay. So we're going on. Okay.
Maybe you say, but I not see what size
The reamer.
do you use?
The reamer, the size of the reamer.
Reamer
Scope.
Scope. What
It's
size?
the interlaminar scope.
Interlaminar scope.
It's a
6
shorter
millimeter.
scope. Yes.
6 millimeter.
Yeah, the size of scope is the the working channel. The outer diameter is 6.9.
Oh, okay. Thank you.
Yes. 6. No. 6.9 outer diameter. For interlaminar scopes. No, it's shorter than transforaminal.
Okay.
Okay.
Another question, please.
Please.
Di-
No, no.
okay. Did you have a bone graft migration into the spinal canal? Did you have any cases of such patients? After
No,
surgery,
no, never.
Never.
It never happened.
Never happened.
Because you see, initially, when you take the bone graft, it's only from the anterior part of the vertebral body, not from the posterior part of the vertebral body. Then you do the drilling some more in the posterior part. So it's a smaller tunnel in the posterior part. So it really fits there.
Yeah. Okay. And what about PLL? Did you always remain it or elevate or?
For this patient, some part of the PLI I had to remove because this material is extruded outside of the PLL. So I had to remove, but not totally. Not totally.
Okay, thank you.
Okay.
Reamer is 5 millimeter.
Okay, I have a question also. The last question maybe.
All right.
So, you know, the endoscopy, the most important target of the endoscopic surgery to protect the musculature, ligaments, joints. So what is the main reason of or main target of the anterior cervical endoscopy?
Anterior cervical disc.
What is the main advantage, for example, if you accept the cosmetic consensus? What
all
is
right.
the main advantage?
First, there's no implant cost. That's number one. And number two, it can be safely done and it's very fast.
Okay, thank you.
This same patient doesn't have a PLL breach, you go for posterior? Since I agree with you.
Yeah, I can do posterior, yeah. You mean, okay. I have discussed this with the patient and the family, but the problem is it's more central than lateral. So it's going to be, it's probably possible, but it's going to be hard.
Because ACDF in the future is slowly going to be for segmental instability, central disc, and OPLR or PLL breach. Other than that, all the pathologies can be addressed posterior endoscopy. That's what my take home is. Am I right?
All right, yes.
Okay, thank you very much. Now I want to invite the next speaker, Dr. Anand Kavi, please. His topic will be
Indication should be very clear. Only the indication should be very clear, and the possibility of the chance. It has to be discussed properly in a proper venue with the family, not only with the patient. The patient would want anything just to get rid of the pain and the disability, but the family and the team of doctors has to be involved as well.
Thank you.
Thank you.
Good morning, everybody. At the outset, I would like to thank Dr. Shomansur, my teacher of PSLD, Dr. Kangtek Lim, and everybody from the organizing committee for this beautiful conference at Bukhara, Uzbekistan. So thank you very much for inviting me here. Friends, I started my journey in spine endoscopy with transforaminal endoscopy. And then to overcome its limitations, I also learned the other techniques like the PSLD and now the newer technique that is the UBE. So many times when I tried to teach my students they always question me that how do you select which technique should you take up and which one is the best. So I thought I would speak on comparison of all these three techniques. So it is a simple talk with simple comparison. No statistics, it is my personal experience what I am going to share with you. So to start with, I would just show you the three. So this is a transforaminal technique for a disc herniation. So what I am trying to show you here is the surgeon's perspective, the anatomy, the spinal anatomy, what we see in a transforaminal technique is from the side, and what we see is the anatomy is completely different what we see from the interlaminar approach. So visibility is good, instruments have evolved, and the indications of transforaminal surgeries have also evolved. Initially it was done only for central herniations or only the simple soft disc herniations, but now we can target hard herniations, migrated herniations, and for that matter even foraminal stenosis. But yes, when you come across central stenosis or lateral recess stenosis due to ligament flavum hypertrophy or hypertrophic facet joints, it is not possible to target it through the transforaminal approach, and that is where this technique, this tool is very important, and it is very easy to learn for a routine open spinal surgeon to graduate to PSLD because the vision is very good, the approach is very familiar, and you see the anatomy as you see in your training in any other routine open laminectomy or decompression surgery. Let's go to UB. How do we look through the UB? So UB, we have the similar indications that whatever we can do with PSLD, we can do with UB, but only advantage is we have 2 ports. So we have an independent scope here, which is 4 mm size, and which definitely has an advantage here that it gives a better view. So coming to the reach of these techniques, so first the transforaminal surgery. So any pathology in the foramen we can very well reach. So you can target foraminal stenosis, lateral recess stenosis, all kinds of disc herniations in lumbar spine, and you can extend this technique to the thoracic spine as well for thoracic disc herniations very safely up to T5. Approach of PSLD and UBE. So anything that is beyond the facet joint, beyond the superior articular process, any pathology which is compressing the canal there, we cannot approach through the transforaminal route, and that is where we require interlaminar route, and PSLD and UBE are the techniques which are required. Now coming to invasiveness, why we all have migrated from open surgery to endoscopic spine surgery is because to reduce the invasiveness. Because we all understand as surgeons that it is the invasiveness of the approach which increases the morbidity, and that increases the suffering and complications of our patients. And that's why we are slowly migrating to more conservative surgeries. And in that context, I feel transforaminal surgery is the least invasive because it literally cuts only the skin and the posterior annulus. The intervening structures are all muscular, they are dilated, and there is no dead space creation in this technique. Coming to PSLD, I would rate it as the next in the least invasive technique because we utilize the fat atrophy, the fat in the interlaminar area, and practically no muscle teasing is done here. So no scarring. So I feel PSLD has a advantage here in interlaminar approach as compared to UBE. Whereas in UBE, we try to use this interval between the multifidus muscle, the triangular space, also popularized by Dr. Son on his name as Son space. But yes, it is more invasive than PSLD in case of interlaminar approach, because those people who are doing UBE, they would agree with me that initially you need to strip the muscles of the interlaminar space, and definitely that creates more invasiveness. That is because you need to create an irrigation channel, and you need to push the soft tissues away from the bone to create a free irrigation port. And that's why among the three techniques, UBEs I would consider a little more invasive. Let's come to anesthesia. Local anesthesia. So only technique which is possible to be done under local anesthesia today, I feel, is transforaminal endoscopy. The great advantage is the neuromonitoring, higher safety because patient is awake. It is definitely preferred in aged people with comorbid patients. But there are certain problems. It is difficult to extend beyond 3 hours, so multiple level procedures have to be staged. It cannot be done in a single stage. Next is epidural anesthesia, or epidural analgesia for that matter, with sedation. So all the three techniques are possible, but it is difficult in old age patients. Prolonged duration can be uncomfortable, particularly if you are doing a transforaminal surgery. And for me, not a preferred technique for TFE, even for a fusion. General anesthesia, not for transforaminal endoscopy because we are trying to explore the Cambin's triangle, so it is more risky. Interlaminar as well as UBE, it is a preferred anesthesia. Of course, difficult recovery from anesthesia in old and comorbid patients. There is high dependence on oxygen, and we all know all these complications and difficulties what we face in GA. Let's come to the learning curve. For the transforaminal technique, yes, it is targeted. It needs correct trajectory. It needs complete good understanding of transforaminal anatomy. You need to understand the depth perception and telescoping of long instruments through a very narrow scope. So it definitely has a more longer learning curve as compared to the other two techniques. PSLD, yes, learning hand control of instruments in small space is what is required. One-handed use of operating sheath and endoscope is a special skill which you need to develop, and you learn to use the long instruments in and out the tube. So, of course, understanding the flaval anatomy, how you perceive it from the endoscopic view is also different, but it is comparatively easy to understand the structures as approach is familiar for any conventional surgeon. UB, the learning curve is mainly into triangulating the instruments because initially we get lost. The camera doesn't see the operating instruments and a lot of refocusing is required as the field of play is very wide in case of UB. So both channels actually should work in harmony, and for right-handed surgeons there is always a side preference. They prefer to do all their cases from left side. But of course it is easy to understand and it is more familiar. Coming to equipment and cost. So transforaminal surgery are definitely very delicate instruments. We require special instruments. There is a lot of recurring cost involved. So definitely cost intensive transforaminal surgery has more cost involved, so it is costly. Next cost intensive is PSLD. Yes, it also requires a specialized scope and costly instruments, but it has got better durability because we can use larger footprint instruments as compared to transforaminal approach. UB is least cost intensive of all the three techniques, so there is a great advantage here in UB. Higher durability, we can use routine spine instruments. We can do mix and match. It is not system specific. And we can use our routine arthroscopy setup, which is available practically in all multi-hospitals. Let's come to interbody fusions. All three techniques can be utilized for fusion. In case of transforaminal surgery, the limitation is limited cage size as what we saw in the first presentation. So we need expandable cages, but there is a problem of subsidence. Then graft harvesting is from a different site because local autobone is not available, and direct posterior decompression is not possible because we are utilizing a paracentral or a lateral route. Fusion with PSLD, cage placement is more medial. We cannot use a larger banana cage here. More dural retraction is required, and we cannot do it under local anesthesia. Advantages: direct decompression is possible, and it is definitely less invasive. UB, we cannot do under local anesthesia. It is definitely more invasive as compared to the other two techniques. Learning curve is steeper. Irrigation fluid requirement is higher, but the advantages is we can use a banana cage or X-T-leaf cage with more horizontal placement, excellent use of radio frequency for hemostasis, excellent decompression, and ample graft is available locally. Let's come to complications. Transforaminal surgery, there is less chance of nerve injury or dural tear due to local anesthesia. Dural tears can be difficult to manage as if they occur, they are ventrolateral in aspect. Dysesthesia and prolonged radicular pain is very common because of handling of the DRG. Incomplete decompression is also possible in the initial learning curve, and discitis is possible because our approach is intradiscal. Complications of PSLD, incidental dural tears are very much possible and they happen, but they are inconsequential. Larger tears and nerve injuries, they do require repeat surgery. Root retraction injuries can cause post-operative weakness. Hematoma, higher irrigation pressure injuries do occur when people are using pressure systems. Incomplete decompression is possible initially if you do not pay attention to the lateral recess and you just do a flavectomy and leave the patient. And of course, routine wrong level surgery in your initial learning curve. UB, the complications could be due to high irrigation pressure because it has an open system. If the system gets closed or clogged, then it can give rise to increased pressure which can cause injuries. Dural injuries and nerve injuries can be, they are possible, but it has lesser chance than PSLD because of better maneuverability of the instruments and better vision. Coming to my personal preference, in case of all kinds of disc herniations for a lumbar spine or thoracic spine up to T5, I would prefer a transforaminal route because I can do it under local anesthesia. For foraminal stenosis, unilateral complaints, I would again prefer a transforaminal endoscopy. But wherein a patient has got a multi-level central stenosis, I would definitely do a PSLD. And for a tight stenosis or for a fusion, I would consider doing a UB. So that was my brief presentation. Thank you very much for all my teachers, and thank you.
Thank you very much, Dr. Kabi. And the next speaker will be Dr. Hayati, so I take care of the rest of the session. And just for time saving, we have to, if possible, we have to just 3 question and answer and comment, okay? Is there any questions around? No questions? Can I have one question? So I don't want to ask you about, so I don't know about one-portal endoscopic surgery, but if you are doing a one-portal endoscopic surgery, the incision size is 5 millimeter or 7 millimeter, 1.5 millimeter, 1.5 centimeter, and even 20 millimeter. The advantage is different or the same? What do you think about it? So actually, 5 millimeter one-portal endoscopic surgery, 20 millimeter one-portal endoscopic surgery. There are some difference or advantage difference, same? What do you think?
No, as surgeons, we all agree that we are not nowadays interested with the cosmesis. We are not worried about the skin incisions or skin scarring. What we are worried about the soft tissue coverage around the bone, soft tissue coverage, the muscle tissue. So I feel in monoportal surgery, definitely they have an advantage because we do a lesser stripping of soft tissues for the approach and maneuverability of our instruments. Of course, we all are now maybe 20 years, 30 years in our clinical practice. So even the patients which we operated as open surgery with big scars, they did not have problem later in life. I agree with that. But yes, the science is pushing us towards more conservative surgeries, and I feel preserving the soft tissue cover as much as possible is more important rather than the skin incision size or cosmesis.
Thank you.
Thank you.
Okay, next speaker will be Dr. Hayati.
Okay. Good morning, everybody. Dear Chairman, dear colleagues, first I would like to thanks to organizing committee and Dr. Kantek Lim and Dr. Shamansur Shatursano for inviting me. And I'm very happy to be in Bukhara, where is very historical city. Then my topic will be about the combination of the two different techniques. So first of all, I want to give some important messages for the young surgeons. Yes, is the endoscopic surgery a miracle? Perhaps endoscopic surgery a miracle for many stations, especially when you think about the complications of the instrumentation and the instrument-related complications. But if we consider about the physics, endoscopic techniques still have many restrictions that some of them listed in this slide briefly. So we will talk about the combination of the monoportal technique with the biportal technique, because I'm feeling the necessity of the combination of the techniques. Why? Because the UB has some restrictions as monoportal or full endoscopic techniques. Firstly, we will discuss about the physics related restrictions of the UBE technique and combine with the monoportal endoscopic technique in this presentation. The other restrictions or limitations or insufficiencies must be another speech topic. The physical restrictions can be visual insufficiencies and technical insufficiencies. Yeah, these are the common problems in all endoscopic methods, the visual insufficiencies. The visual insufficiencies can cause us from angular discrepancy between area or surgical field and optic systems. Sometimes we can see the field, but recognizing the details can be difficult. It may cause us from the insufficient resolution. So the clearness is well-known insufficiency for optic systems, and it can be solved easily. If we check the solutions in angular discrepancies, maybe we can use the different angled endoscopes or scopes. And the resolution dependent, the limitations needs more development of the optic systems. And also, you know, the clearness is maybe the most easy solve the limitation. Another problem is the technical insufficiencies. This means that surgeon cannot control of some points in the surgery. Please see these pictures. UB has biportals and very versatile technique. But because of physics, the ipsilateral fields generally can stay in the shadow. So maybe you cannot reach to the ipsilateral the points easily. So we have talked about some unreachable points in UB surgery. If you want to check these points on the real anatomy, we can summarize the unreachable points for the UB paramedian approach. The lateral portion of the facet joint, cranial level of the pedicles, and the caudal area of the ipsilateral foramen. As I said before, physics is limiting the endoscopic techniques, and it's creating the blind spots for us. Some of blind spots can be relative, which means that you can reach and intervene weakly in the same spaces. And others can be absolute blind spots, which you cannot reach or you cannot intervene to these areas. So what should be our solutions? Actually, there is no way without addition to the other intervention. Addition of the paramedian or paravertebral UB, the approach, or you have to add another technique instead of approach. Same technique. In this case, after decompression successfully, you can see there is no pointer, okay. L4-5 level, still there is a compression in the left foraminal region. Also, there is a disc herniation in the far lateral region. It is possible to reach to the far lateral or outside of foramen by paramedian, the paravertebral approach. So we performed the paravertebral UBE approach to make the compression and the discal fragment removal. In second video, you see the decompression and discectomy. First, we're going to resection the facet joint partially to see the SAP, and then we're going to drill the same lateral edge of the lamina and superior component of the facet joint. Then we did disc removal and finished. After all this, patient was okay, but let's see there are incisions. You see, this picture saying something to us. Please pay your attention. If you paravertebral and paramedian you be in same site, you will have like that approach. In this situation, paravertebral muscles can be affected more than single same site UB. Or if you insist, it can be cause more muscle violation besides facet joint violation, also possible. So it is not appropriate to force the UB technique in this situation. Instead of more aggressive surgery, we can use more comfortable technique as combination with the UB. As a result, if there is a complex compression in same site, even in contralateral site, it is possible to go with another way to prevent the more innocent tissue from the violation. In this case, we prefer use a full endoscopic technique for foraminal disc pathology after central or recess decompression. Then, this is the after central intervention surgery. Then after foraminal surgery, you can see the differences. And we have this picture after surgery. As a result, we could prevent it to the paravertebral muscles and structures when the endoscopic technique were combined. And we have many cases with this technique. So you see the results very well. As a conclusion, UBE has big advantages about the decompression in multi-level and multi-located stenosis. UBE has some limitation in access to some lateral foraminal area, same lateral foraminal area. Adding monoportal technique for same lateral foraminal and extraforaminal pathology has been affect the result. Thank you for your attention.
Okay, thank you for the nice presentation. As I'm a bipolar endoscopic surgeon, but I have to agree there is a limitation for UB surgery. Okay. Any questions or comments about this lecture? Yes.
Thank you for your presentation. I like that kind of the approaches. I call it double approaches, transforaminal and interlaminar.
Yeah.
Also, I did some cases for that kind of approach, but I got a problem of the prognosis because at the same time we do transforaminal decompression and interlaminar decompression. One of the big problem is the instability and back pain.
Instability.
Yes, and sometimes recurrence or sometimes rheostasis I got. So what is the prognosis compared with just one approach and combined approach?
Yeah. Yes, if you're talking about the full endoscopic transforaminal endoscopy, the instability is maybe not so accepting problem, but mainly the instability can cause us from the posterior surgeries. If you violate the facet joint capsules, more than half of them, you can cause the instability. Also, if you have more bony resection, you can cause the, for example, the spinous process fractures, or even in pars fractures is possible. So the combine of the technique cannot cause, but if you prefer the UBE, two approaches in same site, maybe yeah, it's possible to see it. But in transforaminal endoscopy, I never seen.
Yes.
Thank you for presentation, Dr. Hayat Aygun. My name is Doston from Tashkent, and during the 2 days we have some debates of PCLD decompression and UB decompression. Okay. And you said from presentation, big advantages, multi-level decompression central. And we have some problems, multi-level decompression from PCLD with Dr. Shamansur. For example, we have some cases for 5-level central decompression. Each level, it takes approximately 30 minutes, and some complication for this case. And I have one asked, what each level for your take in UB decompression? Thank you.
Yeah, I did 4 level, 3 level. Maybe almost we are using doing the consecutive decompression. Actually, this is another topic, consecutive decompression, because yeah, in your question is very well, but I did PCLD also, but I know the UBE has big advantages, and it takes the PCLD maybe takes more time than UBE, because you can use the very strong and big tools in UBE surgery, but you have some limitation in PCLD, and also you can use the very big size osteotomes instead of drilling, and yeah, you can make short your time. So it is yeah, it's if you want to do multi-level surgery, you have to consider about the time, because the time related complications can be very difficult managed. So doing the surgery is changing the case by case. Maybe mainly I have 30 minutes or 40 minutes, mainly my time. Okay. No, this is different techniques, different approaches, so there is no any concern about the multi-level UB surgeries. No instability, I never seen.
Okay, thank you very much.
Thank you very much.
Let's move on next topic, and I invite world-renowned endoscopic spine surgeon, Dr. Lim. His topic is about decompression of cervical decompression.
Good morning. Sorry, my voice has changed. Good morning, everyone. My name is Lim. Came from Korea. I'll talk about strategy for cervical endoscope surgery. So, in case of the pathology, so what is the best way and the approach will be one of the strategy. Yes, I use the same scope, everything. The one scope. With the one scope, you can do lumbar, cervical, anterior, posterior, everything. So our diameter is 8.0. The length is 113, the maximum scope. So I think the myelopathy is can be the one of our challenge to overcome difficulty as an endoscope surgeon, posterior approach or posterior decompression or anterior approach, HDAP or decompression. There was the constant debate between the anterior approach and posterior approach in the spine congress, like AO spine, CSRS. Posterior approach, what is the big laminoplasty, right? And the anterior, the colpectomy, and the instrument. So we talk about this, what is best way always in the big conference. But we have another option. We have endoscope decompression. Now we have a new weapon, posterior decompression or anterior HDAP. So I'll talk about this this time. So we have been performing the laminoplasty for myelopathy and the anterior colpectomy. But it's very serious of the complications sometimes. And before, if the patient has the myelopathy, I recommend you should check out dynamic MRI first to know the location of pathology, right? It's the same patient, but the patient has posterior in the extension view MRI, posterior pathology, ORF. It's the one main cause of the myelopathy. That's why, so we can do posterior endoscope decompression is a good option. So I recommend it. Anyway, the endoscope surgery you can do, the anterior approach, depend on pathology, anterior approach, or posterior approach, spinal cord decompression. Yesterday I talked about the multiple level with one skin port, right? You can do full decompression of spinal cord with endoscope. And then sometimes, in case of the anterior pathology, you can do anterior approach, the HDAP. So for the 7 years, I teach some doctor in my hospital, and now some doctor in India that can do that now. It's endoscope HDAP now. I'm happy. It's is that working the audio system? Okay, it's the first the endoscope HDAP 2017. Do you know what it is? It's the EKG. It's not. It's my heart rate. It's my heart rate. Right? First time there was no any reference, no any teacher. So during the operation, it's very to scare me, afraid of anything. But it was 2017 first HDAP. So myelopathy, in case of the calcified disc, is difficult to decompress or remove the calcified disc from the posterior approach. That's why that has to be anterior approach. You can do the remove disc and calcified fragment in the post-operative MRI. The small skin scar. And then push the anterior visceral organ to the opposite side with a finger, and then we can insert the small needle in disc space, and then we can use the serial dilator and the endoscope system. As I told, the flexion neutral extension is quite different. This patient, so I performed the posterior decompression first and the anterior AC depth because the pathology is both. So first we can insert the cage holder first, and then we can set the cage under the endoscope view. We can use the two blade retract for only the skin, and then you can insert. So you can see after removal of the PLL, you can see dura pulsation, and then you can insert the cage. Just 1.5 centimeter the skin excision, and after retraction, the anterior neck skin has elasticity, so that's why the 1.5 the centimeter we can make 2 the centimeter. And the post-operative MRI shows posterior decompression first, anterior. It's good with a small skin scar. Right? It's just 1.5 centimeter. During the operation, right? So I think one of the advantages of endoscopic HDF, that could be the endoscope system will provide good visualization because we use a lot of water. There is no any bleeding, so you can see any more detailed inside the anatomical structure during the removal of a PLL. And finally, we can decompress the full anterior disc. And then the 82 female patient, right side. So also you can do endoscope. The post-operative, yes, 1.5. And then, 5 or 6 myelopathy, male patient, same. It's calcified disc, the same. It's uncovertebral joint. We can expose bilateral uncovertebral joint with a punch, post-operative. So one of the advantages of the endoscope, the HDF could be the post-operative soft tissue swelling is very rare. And then, so esophagus is very important, the structure anterior visceral organ. So same approach is same between the esophagus and carotid cyst. The landing on the endosystem on the disc space, we can do the endoscopic decompression and the cage insertion. The drain is very important to prevent hematoma, like the open surgery. So, as told, provide a good visualization, very safety. The operation time is just around 1 hour is enough. And the post-operative anterior soft tissue swelling is very small. And then it's compared to the microscope HDF. Yes, so dynamic MRI is very important, right? So like this. Pre and post-operative patient have the posterior decompression first, anterior HDF. At the same time, this is my paper of 36 case from 2017. So you can find that the paper in the internet very easily. And I'll talk about posterior decompression indication. First, posterior decompression. It's the first stenosis, right? Central stenosis, and then OLF. So with one of the advantages of endoscopic posterior decompression could be we can do multiple level with one skin port, and there is no any post-operative kyphosis because during the operation there is no any post-ligament complex damage. It's very important to maintain stability. That's why in case of the long level, the stenosis, we can avoid the big open the laminoplasty with us. One skin port, we can do full level decompression. So indication, first we can remove a paracentral disc, foraminal disc using the posterior approach. And the very common case could be the foraminal stenosis. And then I told you multiple level, right? Multiple level posterior decompression. Spinal cord decompression from the ipsilateral to contralateral side, and foraminal decompression, foraminotomy. You can see motor of the sensory rod. As a post-operative, you can see the wider the space of a foramen, but there is no any damage of a post-ligament complex. It's very important. There is no any kyphotic change post-operative. Yes, the strategy could be in case of the foraminal stenosis, just we can do just unlooping for root decompression enough. But in case of a disc discectomy, we have to make the wider space sometimes. The landing point of posterior approach is the medial border lateral mass first. And then we can do laminectomy, and then the facet, and then the foraminotomy, and then we can reach to contralateral side, the over top. So most of the doctor asked me in open surgery, the facetotomy has to less than 50%, but endoscope is quite different. The first, you should check up CT scan. If the patient have the autofusion, what is your plan? My plan is full facet removal, because like this, there is no any damage of post-ligament complex, and the patient have anterior autofusion. In the case, just the total facetotomy is one of the strategy. That's why you should check up CT scan first. Like this, C5 or 6, anterior, autofusion, and disc space also, post-operative. My plan is like this, total facetotomy. That's why you should check up CT scan. It's very important. General anesthesia, and so head is maximally flexed and head up. You know very well this. I don't use the skull, the cramp, and the skin is done. The Siam view, the first medial border lateral mass, and then lateral view. The disc space is a surgical landing. And as I told you yesterday, a two-end surgery is very important, two-end, right, for the cervical posterior decompression. This is one of the advantages of the uniportal endoscope, and another one is the uniportal endoscope view and the target point will be facing in the same direction. That's why you can use a two-end, right? Two-end presses can be stable, I think. Stable. Like two-enders. And during the operation, you can see posterior decompression, first the laminectomy, and then you can do the foraminal decompression. The endoscope surgery will provide a good visualization, and one of the advantages of the unipolar endoscope surgery is yesterday I told you. So no muscle manipulation is required. That's why it's very important, the cervical muscle, That's why we have to preserve as much as we can. There is no any muscle manipulation during the operation, posture approach. Okay, the approach to use a tropism and one level, post-operative, 2 level, and the 3 level with one skin port. Okay. So sliding technique. I told you yesterday is a sliding technique for cervical multiple level decompression, right? Like this. With one skin port, we can do 3 level. Right? That's why we don't need to perform any big laminoplasty for cervical, the OLF or myelopathy. It's one of the advantages of endoscope surgery for cervical, right? 4 level, right? No any damage of post ligament complex, so that's why no any kyphotic change. It's one patient visit my hospital with instability cervical on the dynamic MRI. Patient history was patient got open foraminotomy 2 years ago in different hospital. So the MRI shows left side the big damage of posterior ligament complex. That's why patient have the instability. So I tried the anterior approach, HDF, the post-operative like this. So 1 year later, there was no any migration of okay. So in case of the pathologist located the posterior anterior, the first we can do posterior decompression and then anterior decompression. It's post-operative MRI. And then yesterday, it's two pathology posterior anterior. Right? You can do posterior approach decompression and anterior HDF. You can do pulsation before the implantations. You can apply the ADR also, endoscope ADR. And you can apply the C1 to lesion, right? For the C2 decompression or C1 hemilaminectomy with the endoscopic view. So we will show the C1 and the anterior transverse ligament. Okay, post-operative. So, give me this thing. You know that this video, right? We have so many option weapon, the microscope or the unipetal, bipetal endoscope.
Is this
so,
good or bad?
I think endoscope surgery has to be for the patient, not for the doctors. So you need to think about what is the best way. First, to preserve the facet joint muscle, because the endoscope surgery is main purpose of endoscope surgery could be the preserve of facet joint and posterior ligament complex. That's why we will organize this International Endoscope Cervical Surgery Society, because we have a good option that we need to change for the cervical myelopathy. So please join us, and we can do everything, the posterior decompression and anterior HDF. And this October, we'll organize the endoscopy, first endoscopy, the cardiac workshop and the conference in the USA in October. So I will invite you and please join us in the Professor Kim and Dr. Data, me, I will invite you in the October. Okay, thank you.
Yeah, thank you for the nice, fantastic presentation. So, audiences, questions and comments.
Okay. So I have questions.
Thank you for your presentation. Very nice. I have a question about ACDF. When you impact cage, do you use retraction body vertebra?
No.
So that means you don't use the Casper retractor, right?
No.
Retract,
Retractor
yeah.
bone,
Mm.
retractor body.
Yeah,
The
yeah.
retractor body
Yeah.
extension. Yeah, Casper retractor is that. Yes.
Distractor, right?
Yeah,
Distractor.
distractor.
I don't use.
Don't use. How you how you size to cage?
From the 5 and 9.
So maybe your question
Yes.
will be, how can you measure the size of cage before operation? All right. Okay. How can you choose the right cage size?
Yeah. Before the operation, so we can calculate the disc height. And then during the operation also, we can calculate the disc height. For instance, the process.
So especially when you are doing ADR surgery, we need a retraction first, okay?
Yeah,
and then
during
we
the
can put a cage inside. So that means maybe.
During the operation, we can calculate the disc height, right? 5 millimeter or 6, 7, 8, we can calculate. Depend on the height, we can insert any cage.
So according to your video, so when you're putting the cage inside, just you can push the cage without retraction, okay? So maybe this is the question, maybe.
No, his question was whether we try to use a distractor between the vertebral body for like microsurgery for doing ACDF. So, but according to, as I learned ACDF from Professor Lim, if you use a distractor, it won't become endoscopic ACDF. And that is the advantage we are taking by drilling the end plates to make a space, and that also helps in dealing with the migrated discs also. So not putting a distractor is the advantage in endoscopic ACDF.
Okay.
Another question, please. Could you tell us about follow-up after posterior decompression, flavectomy, multi-level flavectomy, multi-level stenosis? Do you have a long-term follow-up? Is there any recurrence of stenosis in such cases or not?
Contralateral approach?
You show us multi-level stenosis with safe lordosis and posterior decompression endoscopically. Flavectomy, yes? Multi-level, yes?
Multiple level.
No.
Yeah.
Do you have any follow-up 5 or 10 years after the surgery? Is there any restenosis on the same levels?
Yes. Yeah.
Yeah?
We do there. Yeah. With the multiple level, the decompression. Yeah. In the near future, is the most of the spine doctor can do like this for multiple level.
Yeah, but unfortunately, actually, we don't have any that kind of result, long-term follow-up result right now. Okay, but as far as I know, there is some article about long-term follow-up result. You mean, right?
Yes,
So he's asking about you long-term follow-up result.
Okay. I will try.
Yeah, but still, we need time, okay? Because we started endoscopic surgery just 2 or 3 years, maybe.
Yes.
No 10 years. No 10 years. Yes.
Sorry. Okay.
No follow-up, yeah?
In your practice, you had wrist stenosis.
Wrist stenosis.
After 5 or 10 years after surgery. No follow-up.
Yes. It's there is no but I need to check.
Yes.
Long-term follow-up.
Locations more. So especially he's the chairman and we have enough time. Okay, don't worry about it.
Okay.
And I have one question.
Yeah.
Sorry about that. Okay, so sorry. So, do you have any experience of a normal cell line related issue when I'm doing anterior endoscopic surgery?
Yeah, supposed to
So
find
we
out.
often worry
Yeah.
about that there is leakage.
Yeah, but fortunately, there is no any problem. It does, even in case of the C1, the hemilaminectomy, there is no any water, the effect on the brain. It's safe. But you should use the water irrigation with just using gravity. Do not use the water pump.
Thank you very much.
Thank you.
Next, let's move on to the next topic. And Dr. We invited Dr. Modi. Is he here? Modi? No? So sorry, this paper letter is too small, so I cannot see. Dr. Modi, right? Yeah, sorry.
Hazri.
Yeah, sorry.
Muhammad Hazri.
Yeah. Let's start.
Assalamualaikum warahmatullahi wabarakatuh. My name is Dr. Muhammad Hazri from Malaysia. First and foremost, I extend my gratitude to the committee members for extending an invitation to this splendid event. And a special thanks goes to my esteemed teacher, Prof. Lim. While I may not be an expert, but I'm excited to share my perspective as a novice, as a young snipers in this technique. I would like to share a particular case of mine. A 48-year-old gentleman presented with a complaint of left upper limb C6 radicular pain since 1 month prior to admissions, with a positive all the provocative tests, and he has normal muscle power but reduced sensations over C6, mainly sensory of the left hand. So the cervical X-ray shows loss of cervical lordosis and mild submental kyphosis at C67. However, the spine is stable. I'm sorry not to show the flexion extension view in my presentations. So the MRI result disclosed a herniated nucleus pulposus at the C6, C7 disc, leading to the left foraminal stenosis. And remarkably, the radiological finding precisely correlated with the clinical signs and symptoms observed in this patient, which is a clinical diagnosis, and the radiological diagnosis is matched. Okay, so what would be the treatment options? So this is the main discussion topic in my presentations. Since the literature review predominantly support SCDF as a gold standard for these conditions, however, this arthroplasty has gained popularity as mean to mitigate or reduce the risk of junctional disease in the long run. On the other hand, some surgeons continue to opt conventional open or tubular minimal invasive posterior foraminectomy or discectomy, and probably some other surgeons doing anterior discectomy as well without any fusions. However, all the three types of surgery come with their disadvantages, right? As you all know, SCDF is an fusion surgery, and it comes with set of complications, and it also promotes some adjacent diseases in the near future. And CDR is a limited and very strict indications, and I believe is a technically demanding as well, and it's a bit costly, especially in my country. And of course, the conventional posterior foraminectomy, the disadvantage, I think everybody knows that we need a bigger incisions, just causing a ligamental and muscle damage, which should be preserved in any decompression surgery. So for me, in my opinion, the ideal surgical treatment should be, number one, is a motion preservation surgery. It must be a targeted surgical treatment based on the symptoms of the patients, right? And should be maintaining spinal segment stability with minimum musculature and ligamental damage, and able to achieve adequate nerve root decompressions and give a good clinical outcome, as good as a conventional technique. So I believe this posterior endoscopic cervical foraminotomy and discectomy is a good options, and probably I hope become a gold standard, replacing any other type of surgery to deal with these conditions. At its clinical outcome as good as conventional technique, it gives rapid functional recovery, shorter hospital stay, and early return to work. So what is the concern for a beginner? I believe there are few concerns for a junior, especially like me, such as what is the best indication to start with? Is the outcome as good as other type of interventions? Is the procedure safe for the patients and surgeons? How much facet joint I can resect to avoid instability? How to judge whether adequate decompression has been achieved at the end of the procedure, and after how many cases I can master my technique? And last but not least, can I handle the possible intraoperative or post-operative complication well if it is happen, right? So selecting good indications, especially in the first few cases, is important. I think you choose cases that less complicated, cases that you can predict it will give good post-operative outcome, as it will increase your motivations to do more cases. So I believe these three factors is important. You choose a unilateral radiculopathy because of foraminal soft disc herniations, upper limb symptoms more than neck pain, and stable vertebral segment. And please do not worry, as the clinical outcome of this procedure is as good as conventional type of surgery, as proven by many recent or previous research study. Indeed, performing cervical procedure, particularly with inherent risk of spinal cord injury, can be anxiety-inducing for surgeon, and the limited field of view and lack of deep perceptions with a 2D endoscope camera contribute to these challenges, right? And however, the question of how to make it safer is utmost important. So, of course, you have to master the anatomy and surgical technique. Some surgical tips and tricks probably to maximize using a burr to thin out the facet cortex, so that reduces the possibility of nerve injury while using a Garrison Ronger. Of course, a serial eye checking to ensure a correct level, and I'm using a full intraoperative neuromonitoring in all of my cases to avoid unnecessary nervous complication, especially for my early series of cases. So how much facet is another thing that you can remove. So facet resection is an unavoidable procedure, as the nerve root located just beneath the medial part of the facet joint. So extensive resection of the joint will also lead to instability. However, by understanding the facet orientations, if you look at the facet orientation, it's more a transverse orientations, right? And because of this orientation, there are less risk of anterior translations of the segment, the spine segment itself. And please ensure that minimum resection, most of the literature review, it says that no more than 50%, but I believe it depends on the conditions of the vertebra itself. If it is have an autofusion anteriorly, as mentioned, and prof. Lim just now, right, you might able to remove all the facet to ensure adequate decompressions. Right? And this is the most important part of the procedure, how to decide that we had done adequate decompressions, right? So I think it's clear visualizations of both the shoulder and the axilla. I think this is a cephalic and this is a caudate, right? And this is the sensory part of the nerve root, C6 nerve root, and this is the motor part, caudal part of the C6 nerve root. So clear visualization of both shoulder and axilla of the nerve root is important, and you should remove of the adequate amount of this. It must be comparable with your MRI findings, and probing the root ventrally to ensure no remaining unstable disc to prevent recurrence, right? And in my case, I look at the improvement of intraoperative monitoring as my another indicator, extra indicator to ensure adequate decompression in my case. Yes, this technique has steep learning curve, but with a strong determinations, proper training, patience, adequate numbers of cases, will give more confidence to a surgeon. And then study says that operative proficiency can be expected to occur about cases like more than 20 cases. How about the complications? I think everybody will, it's a less forgiving complication if you do, patient cervical cases with a spinal cord injury or nerve root injury. But if we stick to our safety practice, or safety procedure, so we can avoid it from happening. And of course, as I mentioned, and I'm using a neuro monitoring, as it can, give certain advantage, as I can see the preoperative baseline amplitude, which is most of the time reduced if the compression is very significant, and it monitor my intraoperative nerve activities, and post-operative improvement amplitude will ensure the surgery. So what happened to this patient? Of course, I do endoscopic foraminotomy and discectomy. And this is my case. And improvement of 40% of neuromonitor, and patient do very well. So as conclusion, endoscopic is a safe and it also gives an excellent clinical outcome. With that, I end my presentation.
So thank you very much. Great lecture. Okay, questions? Just 2 questions, please. No comment? Can I have a question? One question. So how do you know during your procedure you removed 50% of facet joint? Do you know when you removed the facet joint? I already removed 50% of facet joint. How can you?
Yeah, actually intraoperatively by looking only at the endoscopic view, it's very difficult to see how much we to remove. But I think one of the procedure probably I do is I do a AP what we call an AP II view to ensure that I don't go over limits.
Okay, thank you very much. Okay, let's move on next topic. And next topic is British, please. We are talking about endoscopic surgery for Koda-Ikino syndrome, right?
Yeah.
Good morning, everyone. I thank you, Dr. Somansur and Dr. Akno, for giving an opportunity to talk on the endoscopic surgery. So today my talk is transforaminal versus monoportal versus biportal for Koda-Ikino syndrome. Which one is better? So I'll start with the cases. I will not waste the time in theoretical lecture. It's an 85-year-old male with severe bilateral leg pain, not able to stand since 15 days, loss of urinary control since 5 days, bilateral lower limb numbness, constipation. So this is I don't know, there is a cyst in the dorsal aspect, dorsal cyst in that at level of L4, L5, and patient land up with the Koda-Ikino syndrome. And he's very high risk because when he arrived in the hospital, her blood pressure was 80/40 because he stopped for 3 days anticoagulant, and he had previous history of ischemic heart event. And we found the silent MI on arrival, so and because of raised tropi and BNP, and we treated in ICU for 1 week, and then we took in OR because and he was very high risk. So we did interlaminar endoscopy under local, which we put the epidural catheter if need arise. Patient tolerated surgery well and complete relief of pain post-op. Catheter, we removed the urinary catheter after 1 week and his bladder function returned. You can see the entire dorsal aspect we decompressed very well. We removed the entire cyst. It was cheesy material, yellowish looking, and complete decompression happened. And it's being again 32-year-old lady with right leg pain since 3 months, retention of urine since 3 days, perianal numbness and paresthesia with right S1 weakness. You can see the huge disc, huge disc behind the S1 vertebral body and completely occluded canal, sacral canal. So we did interlaminar endoscopy for this lady. I'm doing little fast. So same principle. I always remove the part of SAP and adjoining lower lamina just to free the traversing nerve root, S1 nerve root, so that we can have very good retraction and we can remove the disc very well. So once we open the ligamentum flavum, the disc is just visualized, and we removed 3-4 very, very big fragment. So this is a final decompression. You can see completely free axilla and traversing nerve root. And here we did little bit of lower laminotomy just to free the disc from the lower aspect. So this is a post-op picture. There is complete removal of herniated material. Again she recovered. She had relief in the pain. She need 10 days catheterization. Again we gave trial on 10 days, bladder function returned, and after 1.5 months she returned her routine activity. This is again one more case, 45-year-old lady with retention of urine, no radicular pain, nothing, only retention of urine. So this is a caudaic venous syndrome mimicking as a conus medullary syndrome. So we found that must be disc at the upper level, but she has a fresh disc at alpha S1 level behind the S1 body. You can see there is a complete occlusion of sacral canal with a herniated fragment. So again we attempted interlaminar endoscopy. And we removed herniated fragment from axilla because it was down migrated, better to remove from the axilla. Again 2 big fragment. There is complete decompression and she again recovers. So what do you think? We should do interlaminar or transforaminal? Which one? But wait, here 24-year-old male, again right leg pain, not able to walk, not able to stand, walk, perianal numbness since 4 days, and he had very big disc herniation at L4-5 level with complete occlusion of canal. I attempted transforaminal endoscopy because he's a very young gentleman. I don't want to remove any bone in this patient. So you can see there is again very good decompression dorsolaterally and ventrally also. Again he recovered his function. One more guy, 37-year-old male with left leg pain since 3 months, sudden onset of left foot drop, not able to walk, loss of urinary control since 1 day, catheterized because of retention. We did emergency surgery on the same day. So he had L3-4, huge disc, central as well as right paracentral. Again we did transforaminal endoscopy him.
Last 2 minutes.
Yeah. He nicely recovered his foot drop even and bladder function also. So again, which one is better, transforaminal or interlaminar? So we say, okay, both are good. But wait, this is the last guy. We did a 58-year-old male with severe bilateral leg pain, right side more than left side. Again, urinary retention since 15 days and bilateral foot drop. You can see huge disc behind the L5 vertebral body and severe canal stenosis. So some kind of interlaminar approach must be better. So we attempted UB in this patient. And we achieved very nicely bilateral decompression with complete removal of fragment. So this is the last one, 42-year male with cauda equina syndrome. You see the very severely narrowing canal and disc herniation. So again we attempted biportal endoscopy in this man. So complete bilateral decompression, and he also recovered very well. So which approach is better, when and why? So there is always mystery. Every time we just ask, I do transforaminal, I do interlaminar, and I do UB. So everybody debate which is they doing their best. So in conclusion, it is always debatable which approach is best for particular pathology. Again, if you are comfortable with particular approach, choose that approach. But 360 decompression, anterior as well as posterior, is very important in cauda equina syndrome. But for me, if you ask disc pathology, soft disc pathology at level of L4-5 or above, I choose transforaminal burst because less handling of thecal sac and sacral nerve root. Pathology at L5-S1, better to do interlaminar because iliac crest and large facet sometimes going dorsally is very difficult. And again, always listen to your master, which will again shorten your learning curve. Thank you.
Thank you for your excellent presentation. We have just a short time for just one question.
Any questions?
Okay, there is no any question. So I want to invite the next speaker. Dr. Abdul Basit Molvi will talk about the endoscopic fusion past, present, and future. I will warn you about the time. Dr. Molvi.
Yeah.
Sometimes I can warn you.
I thank Dr. Shomansoor, Dr. Lim, and respected moderators for inviting me here. I'd be talking about endoscopic fusion. I work in Manath Hospital, India. So spinal fusion is a surgical procedure that permanently joins two or more vertebrae in the spine. The surgery is essentially a welding process that fuses vertebrae together. So now the question arises, why fusion? When we look at the severity of spinal diseases in the early 19th century, there were a lot of traumatic injuries, congenital defects, Pott's disease, which caused a lot of neurological impairment and global disability. And physicians or surgeons were not able to do much with them. It was only in early 20th century that two giants of spine surgery, Russell Hibbs and Fred Elby, pushed the boundaries of science by performing fusion in Pott's disease without instrumentation. With the advent of pedicle screws, interbody devices, osteoconductive and inductive bone grafts, the fusion process became easier. And over the past 5 decades, the development in the fusion techniques also evolved. And we also understood the biology and biomechanics of the fusion mass better with time. So when we look at the historical overview, we see that the first lumbar interbody fusion, the posterior lumbar interbody fusion was described by Cloward in 1940, and transforaminal lumbar interbody fusion was described by Harms and Rolling in 1982. And these procedures helped a lot of patients, and it helped all those pathologies which earlier we were not able to deal with. So, but there was a lot of problems associated with these procedures, that there were a lot of post-op comorbidity, infections, skin problems, muscle necrosis. So surgeons wanted something which will give early rehabilitation and better post-operative outcomes in their patients. So in order to achieve that, it was the first MIS fusion that was done by Kevin Foley and Michael Lefkowitz in 2002. And it in a way solved a lot of problems that were associated with open procedures. If we come at the disadvantages of open and MIS still, if we'll see that with open procedures, longer skin incision, muscle stripping, greater blood loss, epidural fibrosis, and higher chances of nerve root injuries are there. And we also see most post-operative pain associated with these procedures. And there is increased skin necrosis due to MIS retractors, denervation and necrosis of spinal muscles with prolonged use of MIS retractors. And there is also segmental artery injuries, and you can see in transverse approach there are also neurological problems associated with these procedures. So all these open procedures, they cause a lot of skin dehiscence, skin problems, muscle necrosis. So every surgeon wants in his patients that there should be less risk, less cost, and better outcomes. And in order to achieve that, we see this is a good paper which says that validation of the benefits of ambulation within 8 hours of elective cervical and lumbar surgery helps in improved outcome in the patient. In order to achieve that, we wanted a procedure that will help in early rehabilitation. We want our patient to be out of the bed as early as possible so that our results are better and outcomes are better. So the first endoscopic fusion procedure was done by Dr. Morgenstein in 2007, and he published his paper in 2010. And it showed very promising results that patient was discharged within 24 hours. There was less post-op pain, early mobilization. VS score was at after 24 hours was almost 0. So the advantages are clear, that it's a less destructive procedure, less muscle and epidural fibrosis, less chances of nerve root injuries, less post-op pain, better cosmosis, shorter hospital stay, faster rehabilitation, and preferred option for comorbid elderly patient. And this point I like the most, it's a good option in revision surgeries. So this is a graph which shows the beauty of the endoscopic procedures, that the visualization is the best, incision is the least, and retraction is almost nil. So these are some of the indications of the endoscopic procedures. So how we do it? I'll be talking about the trans-Campin or trans-SAP approach in my talk. Usually take the end plate view, approach corridor is along the disc, and skin incision is usually 8 to 12 centimeters of midline, which depends on patient size, facet size, or spinal segment which we are treating. And I usually prefer trans-SAP access because it helps me in 2 ways. It helps me in protecting the exiting nerve root. It also helps me in putting a larger size cage through the Camden triangle. And I always do foraminoplasty with the reamer so that I put a larger size cage through this approach. So I use a rectangular dilator in order, which helps me in 2 ways. This dilator helps me in protecting the tissue and exiting nerve root during cage insertion. It besides helps me putting bigger cage with smaller skin incision. This is the rectangular dilator which I use along with the reamers. You can see in these images. And this is the video here. You can see very well prepared end plate. Usually open surgeons do not agree that you have a better view of end plate preparation with endoscope. Usually we use curettes, steel brushes, and shavers to prepare the end plate. And after preparation of the end plate, we put the interbody cage and osteobiology. I use demineralized bone matrix. I prefer expandable cage over static cage because it gives me better restoration of disc height, efficient indirect decompression, excellent fixation into vertebral end plates, and smaller incision is required to place the expandable cage and less chance of nerve root injury. This is the video after. Now I'll be discussing some of the cases. These cases are not here to show that the endoscopic fusion is the best, but it is a very important tool in the hands of a spine surgeon. He can have this tool in his toolbox that he can offer to his patients, especially to those who have where you have to do revision surgery. This is a case of a 32-year-old female with lower back pain, radiation to left lower limb. You can see there is grade 2 spondylolisthesis L5S1. This is the end plate preparation of the patient, very well prepared end plates. And this is the post-op when we put the endoscopic cages, expandable, and restoration of the disc height was done. And here you can see patient is walking just before discharge. This is 24 hours after surgery, patient is walking comfortably. This is another case of degenerative listhesis L4, L5 with bilateral lower limb pain, back pain. This is after endoscopic fusion. This is a case of 41-year-old male with lower back pain, radiation to the right lower limb. Microdiscectomy was done around 1 year back. After surgery, patient complained of severe back pain. There was though some relief in the leg pain. You can see there are end plate changes and retrolisthesis at L5S1 level. This is the here you can say there is decreased disc height, and also there is big chunk has been removed from the right facet. And here after restoration of disc height and endoscopic fusion, and lordosis has been maintained. You can see this is pre-op, sorry, the post-op. This is the post-op just before discharge. This is a case of 47-year-old female who had severe back pain, and there was L4, L5 retrolisthesis with reduced disc height. Here you can see foraminal stenosis is there at L4, L5 level. We did the trans-SAP interbody fusion in this patient. Disc height restored and foraminal height restored. Here you can see this is the pre-op video of the patient. This is 12 hours after surgery, and this is 2 weeks post-op. You can see patient walking comfortably with a smile. So this is a case of a 65-year-old male with 2-level disc collapse, foraminal stenosis at L3, L4, L4, L5 level. This is the MRI of the same patient. We did the trans-SAP endoscopic fusion, and here you will see the pre-op and post-op, and you can compare. After post-op, patient was walking comfortably. This is a 60-year-old female with lower back pain, radiation to bilateral lower limb, claudication distance around 50 meters. This was the flexion extension view showing instability. We did endoscopic fusion in this, and this is the post-op just before discharge, 24 hours after surgery. This is a good case to discuss the advantage of endoscopic fusion. This is a case of tuberculous spondylodiscitis, L4, L5 level. This is the MRI of the patient, and we did endoscopic fusion at L4, L5 level. You can see the patient is not able to sit properly on the wheelchair. This is after surgery. Patient is comfortably walking just before discharge. The main advantage of these endoscopic procedure, endoscopic fusion, is in the revision cases. This case has been operated 12 years back by open procedure, and he had degenerative spine. He complained of severe back pain, but there was no radiation to lower limbs. So you can see degenerative scoliosis. We did endoscopic fusion in this patient, and patient responded well after surgery. And this is the video of the patient just before discharge of the patients. So this is our paper on Cambion trans-SAP interbody fusion with our experience with rectangular dilator, 32 cases, and it shows promising results. And we see there is early rehabilitation of the patient and less post-operative pain with these procedures. But I'd like to discuss some of the limitations of endoscopic fusion. The main limitation is it is only limited to the endoscopic surgeons, and equipment cost is high, steep learning curve, time consuming, and endoscopic interbody cages are smaller, so there are more chances of subsidence. Endoscopic expandable cages are expensive, so cost is the problem with some patients. But I'd like to just put your attention to one of the problems that usually we face when we do these procedures is the post-operative radiculitis in some of the patients. It usually the onset is usually 2 to 3 days after surgery, and surgeon must be aware of it because we have already discharged the patient, and patient comes back to the hospital and says he's having severe pain. So this pain usually has no motor weakness of the affected root, but good news is that it's a transitory pain. It will resolve by 3 to 6 weeks. We give gabapentin, pregabalin, and steroids, but the problem is that it causes a lot of post-op noise in the hospital, so it's best you should counsel the patient that with some patients, it's usually with those patients where you put larger size cages or you do reaming of the SAP with more than 12 reamers. In those patients, it's there. These are the just advantages of the endoscopic spine surgery, and these are some good reads. One should do read these papers before starting the endoscopic fusion procedures. And in the end, I'd like to say that endoscopic fusion will be the future. Thank you.
Thank you very much for your good presentation. So we have just one question time for. Do you have any question?
So thank you for your nice presentation. And when you are doing endoscopic fusion surgery, if you need to do a reduction, do you have any tips for reduction maneuver or procedure when you are doing endoscopic surgery? If you have, just explain to us. Reduction maneuver. When you have two or three grade high recesses, sometimes we need to correct recesses. We need a reduction.
I initially used to do reduction first and then put the cage, but I now do put the cage first and then do the reduction. I think it's almost same both ways. Initially, I used to reduce first and then put the cage. Now I put the cage first and then reduce. I feel no difference in it.
Okay, thank you very much. Now I want to invite Dr. Nantavat Utamo. His topic will be extraforaminal disc herniation, a comparison of surgical technique between full endoscopic discectomy and UB. We have time, 10 minutes, you know.
Okay.
Okay. Good morning, Chairman, moderator, and everyone, and salam, everybody. And thank you for having me. Today, I would like to present about the extraforaminal disc herniation comparison of a surgical technique between the full endoscope and the UBE. Okay, extraforaminal disc herniation occurs around 6 to 12% of all lumbar disc herniation. And according to the unique anatomy at this area, the surgical approach is different that of the intracanal lesion. And here, facetectomy is almost inevitable, and the soft tissue damage often occur. And the modified Bussey approach was developed to reduce these problems. By the way, these approaches are often associated with a partial bone removal and therefore increasing the risk of spinal instability. Professor Cambin described the uniportal arthroscopic discectomy through the Cambin's triangle. The indication to use endoscopic discectomy technique have since changed, and many approaches were developed for the foraminal and extraforaminal lesion. For transforaminal technique, the needle insertion is around 7 to 10 centimeters lateral from the midline, and the angle of the needle is steeper than the conventional technique. In this case, full endoscopic lumbar discectomy was performed by the transforaminal technique. As described before, a needle insertion was about 8 centimeters lateral to the midline, and the target to the junction between the SAP and lower pedicle. After that, the sleeve and the endoscope was S1 to the target as shown in this picture. And first, we clean the soft tissue around the starting point of the SAP and the pedicle by the RF coagulator and identify the foramen. And beware the bleeding from the branches of the radicular artery. Then gently move a sleeve and the scope to the cranial side because where the nerve exit was not clear and we don't want to cause further injury. Then clear the foramen and identify the disc herniation. Okay. And you open the annular with the longer and we can find the disc fragment. Remove all of the disc fragment with the punch. Okay. And after that, the annuloplasty was done by the coagulator. And finally, confirm there's no more root compression by checking its tension. For the UBE or best technique, use a two portal. The key of the UBE is to build a triangle and create a potential space at the target area. The distance between the two portals is around 2 to 3 centimeters. And for extraforaminal lesion, there are many initial target points, depend on the lesion. Example, the Uzmiss approach or accessory approach, or some use a target as a base of the TP, and for the L5S1, we use the ALA approach. And the incision, portal incision is usually 1 to 2 centimeters lateral to the target point. And UBE was done in this case with the paraspinal technique. And according to the extraforaminal lesion, I use the accessory approach in this case. And first, we clean the soft tissue, allow lower part of the transverse process, lateral isthmus and SAP2. And then do the accessory process and the lower part of the TP until the ligament was released from the bony structure. And be careful the bleeding from the branches of radicular artery. Then gently remove ligament and the soft tissue until the exiting nerve root was observed. And then identify the space between the SAP and the exiting nerve root to find the disc herniation. And detach the disc fragment from the nerve root and remove it. And then annuloplasty was done by the coagulator. And finally, free exiting nerve root was observed. Comparing the technique between two approaches, the full endoscope can perform under the local anesthesia and general anesthesia, but the UBE is usually performed under GA. And the target point of the full endoscopic is the junction between the SAP and the lower pedicle. Why? The UBE has many targets depending on the disc level and the lesion. And the disc herniation can easily be observed in the full endoscope, whereas the UBE technique, the exiting nerve root need to be identified before discectomy could be done. And due to its special instrument and the unique approach, more learning curve is required for the full endoscopic technique, while the UBE technique is similar to the microsurgery. And although full endoscope can directly remove the disc herniation and causing the less harm to the other structure and require shorter operative time, the nerve root injury can occur due to the needle insertion and sleeve movement. And according to the wider endoscopic wheel and the movement of the instrumentation, the UBE can manage a combined lesion properly. And by the way, the massive bleeding can occur and the retroperitoneal fluid collection can happen due to the improper management of the in-outflow of the normal saline. In conclusion, the wheelchair approach is still a gold standard for the discectomy and extraforaminal disc herniation. And nowadays, endoscopic surgery has more role in management of disc herniation. The full endoscope transforaminal approach can directly handle this problem and is less invasive, while the UBE technique can give wider wheel and more degree of the movement and similar to the microscopic surgery. And however, both technique can give a good outcome as a gold standard. So understanding both of them lead a better decision and patient outcome. Thank you very much for your kind attention.
Thank you for your good and excellent presentation.
Yes.
Just we have one question time. Do you have any question? Okay, no, just I have a question.
Yes, please.
Do you think about which technique is simple for the beginners? Full endoscopy or UBE?
The simple, I mean that, in my opinion.
Or easy, which technique is easy to learn?
Actually, if you do the open surgery or microsurgery familiar before, I think the UBE is the same technique. But if you have some training with the transforaminal approach for the full endoscope, as you familiar to put the needle, and so I think the full endoscope is more easy and shorter time.
Okay, thank you very much. Now I would like to invite the next speaker, Dr. Alex. Okay. So you. Okay. Okay, you can start. So.
Good morning, everyone. First of all, I want to congratulate Uzmiss second International Spinal Stenocopic Surgery Conference. I wish you a great success. The second is I apologize for my absence due to my visa problem. So I am Eugene Lu from Taiwan Lincoln Chang'an Memorial Hospital. I want to present my CULB data. First of all, I want to talk about cervical disc degenerative disease. It all comes from disc height decrease causing kyphosis. The basic problem is radiculopathy, and the advanced problem is myelopathy. People say the ACDF is the gold standard treatment for cervical disc disease. However, this fusion surgery causes limitation of motion, adjacent segment syndrome, and the ADR is only partially physiological and still have certain ASD rate. So the last year, the Netherlands posterior randomized control trial showing that the posterior cervical foraminotomy without resecting the disc and the fusion the disc to treat the cervical radiculopathy has very similar result to ACDF It is non-inferior in the arm, neck, VAS score, NDI score, and all the adverse events. So let's see how endoscope developed. To see the evolution of spine endoscope from first generation to third generation, it all becomes shorter with wider working channel. That means the interlaminar or translaminar posterior approach will get more and more importance. So let's also see the cervical spine anatomy. Compared to the lumbar spine, the transforaminal is impossible in cervical spine because burden artery is sitting there. So the posterior approach in cervical spine endoscopic surgery will get more and more importance also. So from when I learn the PECD or PECF basic technique, I need to learn the partial pediculotomy or partial vertebrotomy to reset the disc without retracting the neural structure. So this is the typical case in my hospital. 2-level lateral HIVD. I do nerve block before the surgery. So this is how I do it. For this, I already augment the B point, resect half of the pedicle, and the root is pushed upward cranially. The roots become inflamed, flat. So I do a small annulotomy, gently touch the annulus to let the unhealthy disc coming out. So after removing all the disc, so the root will come into its original place and become much less inflamed, become round without compression. So the result will be very promising. More than 100 cases. So I am very confident in doing 1-level, 2-level, or 3-level treatment using Dr. Lim, the sliding technique. So the results are all very promising, not only in 1-level, but also in multi-level treatment. So after I'm confident in PECF, PECD, I want to move to advanced, to treating the cervical myelopathy, CSM. So let's see the pathophysiology. It comes from the disc height decrease. So on tethering of the yellow ligament become buckling. So the hypermobile of the cervical spine causing repeated contours in the spinal cord. You can see Dr. Lin's dynamic MRI result. So it's very reasonable from posterior approach to remove the yellow ligament to solve the compression problem, to solve the myelopathy. It is also very reasonable from PECD, PSF to CULBD by just tilting the endoscope. So when I see the nomenclature, I see CULBD is already there in posterior category. However, there's limited publication. That means everybody is in the beginner stage. So for patient safety first, I want to see if I'm well equipped. The first, if I have a good endoscope. So I have the 12 centimeter long, 6.0 mm working channel endoscope. I also have a shorter one with 4.7 mm working channel dorsoscope. So that means I can do ipsilateral and the contralateral approach. And then you need to have a variety of instruments to treat different angles to decompress. The third is compared to the lumbar ULBD, what's the difference? So lumbar ULBD, there are 3 spaces you need to decompress: bilateral yellow ligament, bilateral lateral recess, contralateral foramen. And for cervical lamina, it's more flat. So you need to reset the spinal process generously and reset contralateral lamina sometimes totally, and just preserve the distal ligamental complex in between the spinal process to get the fully central decompression. And you can also do bilateral lateral recess decompression. But for contralateral foramen decompression, for my personal perspective, is very dangerous. You cannot avoid touching the spinal cord. So the following is my 10 steps. The first, I use tape to semi-rigid fix the head. I avoid exaggerated inclination because you will create insufficient decompression when you do the surgery. The second is photo design. You can use central approach or direct lateral mass approach. I recommend direct lateral mass approach because you can not only decompress ipsilateral foramen, you can also tilt the endoscope to decompress the central canal. For muscle approach, because the cervical muscle is more cruciate, interactive, more layer of the fascia in between. So I will suggest using sharp dissection with the blade, direct to the V point on the C-arm, help you introduce the obturator smoothly. Avoid using the K-wire because there's a case report to penetrate through the lamina bone to hurt the spinal cord. The fourth is soft tissue removal. It's easy. You can touch the V point, use your grasper to sense how much soft tissue left you need to remove. And then you do ipsilateral decompression, contralateral over the top drilling for contralateral bone and the yellow ligament decompression. And the most important step is ligamentum flammum removal. So after lifting the ligamentum flammum from the spinal cord, you have two methods to remove the ligamentum flammum. The first is piecemeal. The second is en bloc. Recently, I use more en bloc approach because leave the yellow ligament there can help you from the pressure direct to the spinal cord. And en bloc approach can avoid repeating maneuvering your instrument to the spinal cord. After all, you inspect your decompression if enough, and then you insert the drain, hemostasis, and then you close the wound like this. Let's see the video. The first is soft tissue removal. You touch, you feel the bone, how much soft tissue you remove, and you remove the lower margin of the cranial lamina, and you remove the upper margin of the caudal lamina. And after remove all the bone here, you can see the margin of yellow ligament. This is the upper margin of the yellow ligament, and this is the lower margin of the yellow ligament. And after you reset the spinal process space, you can en bloc, removing the yellow ligament after lifting it, and you can see the cord will decompress after this. If you want to do contralateral lateral decompression, you need to aggressively remove the spinal process space. Sometimes even contralateral lamina bone totally remove, and you can safely remove the contralateral lateral without touching the spinal cord. And then you can see your CUOBD is done here, like this. So I have 7 cases, 1 level 2, 2 level 3, 3 level 2 cases. So the first case is tongue cancer, CCRT, anterior neck, severe fibrosis, poor nutrition, cannot do ACDF. I suggest doing CEULBD and well decompression, symptom gone. The second case is a trauma case, floating lamina. So left limb numb and the weakness. I use CUOBD, just remove the floating bone, not interfering with stability after the surgery. Third case is jumping stenosis. Just received CAD stent for 3 months. So he cannot stop antiplatelet. If you do ACDF, you have a very big wound, a lot of bleeding. So I do 2 incisions, 3 level CUOBD decompression, symptom count, well decompression. The 4 cases, I just want to show the postoperative CT scan, how much procedure I remove, but without interfering postoperative stability. So all the outcome is very promising. The neck pain and the arm pain all significantly improve. Doesn't interfere the cup angle, not causing kyphosis. Compared to other people result, 2005 Japanese group, endoscope bilateral laminotomy, JOA VAS score improved. What's interesting, after 12 years, the same group, they changed to microendoscope technique, changing to ULBD, not bilateral laminotomy. And they compare their cases with laminoplasty in treating CSM. They found the 5-year follow-up, the ULBD group has much significant less kyphosis change compared to laminoplasty. That means the ULBD will preserve more ligaments, more muscle, and prevent the kyphosis change. And the third publication is from Seattle, University of Washington, Crystal. 10 cases, CUOBD, new regrade, JOA, all significantly improved, very similar to my study. And the 4 cases is Chinese group. Compare ACDF and the CUOBD, the disc change, the 2 group is the same. So my conclusion is CUBD is a novel treatment strategy to offer reasonable treatment, especially for all patients who maintain an active lifestyle. And it is much less stress compared to traditional any cervical spine surgery inpatient. And it allows shorter stay and a happy discharge. For my take-home message, is before you embarking the CUOBD, you need to be careful of three things. The first, loss of control is unforgivable of three tools, which is tubular sheath, endoscope, and the surgical tools, because loss of control will hurt in the spinal cord. And there's no enough evidence comparing to the air-based cervical spine surgery to fluid-based spine surgery. So you don't know how fluid pressure will interfere the myelopathy. So if you feel it's dangerous in very tight CSM or OPL, choose the traditional air-based surgery like laminoplasty. The third is spinal process base need to be undercut generously in order to allow a working trajectory to contralateral side without any pressure onto the spinal cord. In the end, I need to thank to Dr. Lin for teaching me all of this about PSLD, PSCD technique. And I also thank to the conference organizer, Dr. Arka. This is our photo in India. Thank you.
Thank you very much to Dr. Alex Liu. Now, I would like to invite the last speaker of the first session, Dr. Vishendra Saidlab. He will talk about the PCLD TLIF, pitfalls and instruments. We have 10 minutes.
I want someone. Good morning, friends. It's a prestigious opportunity to work under Dr. Lim and to present under Dr. Lim's conference about our work of an endoscopic journey, quite long. We started from 2016. It is an 8 long years journey, just 10 minutes to discuss about it. Today my topic is PSLD, TLIF, tricks and pitfalls. What are the best ways to do it, and what is the difference between doing with a biportal and monoportal fusion? What are your expectations and what results you want to expect? So why endoscopic journey? We already discussed a lot about it. We'll discuss about operative steps, the current position of spine endoscopy and personal experience. So of course, for any kind of MIS surgery, it is the smallest possible footprint. That is the outcome of in monoportal, the footprint is quite less than biportal. Minimal collateral damage, achieving a similar goal to that of open surgery. And of course, better functional outcome, which is very much directly proportional to the amount of muscle damage. So what is collateral damage? Collateral damage is injuring paraspinal muscles, interspinous ligaments, supraspinous ligaments, lamina and the facets. They all affect the sagittal balance and patients end up with instability. So these are the cadaveric cross-section of the patients, and these are the post-operative MRI for open surgeries for single level. So from here we started, and now from the open surgery to the tubes to the micro to the micro endoscope. So surgical loops, microscope, endoscopic assisted like dust angio and UBA, and then slowly now the monoportal. So of course these are the scars of the open, mini open and the endoscopic surgery. What is true endoscopic surgery? A incision less than 1 centimeter, no muscle cutting but only splitting, preserve the supraspinatus and interspinous ligaments, which is very much important for the sagittal balance. So a small graphic, what is interlaminar axis? Interlaminar axis is both monoportal and biportal, both come under interlaminar axis surgery. So if you ask me endoscopic surgery, there is only 2 forms. One is a transforaminal surgery and other is interlaminar axis surgery. In interlaminar axis surgery, it is either monoportal or biportal. Just you enter the interlaminar window, bypass all the muscle, and your starting point is just the bony structures. So 2 approaches, only 2 endoscopic, one interlaminar and one transforaminal. So indication started with disc prolapse, all paracentral, foraminal, extraforaminal, central canal, lateral recess, now listhesis, facial cyst. So of course, this is what the positioning we take like. These are the steps of using of dilators to go into the interlaminar. As already it has been discussed, I'm skipping it. Why it is good, endoscope, monoportal? Because of the maneuverability. You can visualize whatever you want. You can see the ipsilateral, you can see the central, you can see the contralateral route. So maneuverability and visualization is always a key factor for complete surgery. You can look at all the corners of the spine. It's not that you have a fixed vision. So I can go to the shoulder, I can go to the axilla, I can go to the contralateral route. I think you can appreciate that. I'll be showing the contralateral also. Yeah. So you can see the contralateral route and you can see the contralateral foramen also. So the advantage is maneuverability. Of course, small scar and minimum surgical footprint. This is the post-op MRI of a patient of L4, L5 disc herniation. We have done decompression. You can see the differentiation of the footprint of the open and the endoscopic. So these papers has already been discussed why endoscopic surgery is picking up. So of course, everything comes with meta-analysis and of course studies. We publish more, the chance of the evidence-based medicine picks up. So these are the number of publications which have come from the last 2 years. We have around a spike of 400 papers from the past 4 years, and last year and before last year is more than 400 papers. Highest were coming from China and next is from the South Korea. So what are the superiority factors and what are non-inferior factors for endoscopic spine surgery? Definitely functional outcomes, duration of surgery, length of hospital stay is less in endoscopic spine surgery. While the not so big difference with micro is visual analog scale, recurrence, reoperation, a return to work period is almost similar. So this again surgeries were multiple studies which so this is a spike of publications which prove that endoscopic surgery is going to be the future. So we see, I show you China has published 402 papers, next comes the South Korea, next comes the USA, Japan, Germany. So which it's high time for us to publish more. So now we speak about indications and contraindications of endoscopic translumbar intervertebral fusion. So initially interlaminar technique was used for doing only decompressions, then slowly foraminal decompressions, contralateral decompressions, and most asked question was what you do about degenerative listhesis or what you do about instability. So we have evolved to do fusion and we have some expected outcomes to do. So indications are lumbar foraminal with segmental instability, lumbar disc herniation with segmental instability, and spondylolisthesis not more than grade 2 because it's not easy to go good reduction. So these are the special instruments which we have evolved into for doing the end plate preparation. In UBE, you can use the normal open reamers, open stuff. Here, we need a reamer which goes through the scope. So these special surgical instruments involve reamers. We also involve cage sizers, and we have something called angled curettes. These things go through the scope and these help us for preparation of the end plates. That is a difference between endoscopy and open surgery. So the pitfalls to get a good T-leaf is always proper end plate preparation with less subchondral damage. So less subchondral damage makes us the chance of the cage substance very less. So visualization of good end plates which is possible in biportal and monoportal is a success, which is more better than in open T-leaf where you do the end plate preparation blind. So and ultimately is the resection of the SAP is very much required because as we have a common entity, we say instability or listhesis is always a exiting nerve root pathology. It is not traversing root pathology. Maybe disc can be there, it can be, but always exiting root pathology is with instability. So exiting root is not decompressed interlaminar root if you not resect the SAP. So it will become a P-leaf which it prevents fusion if you don't remove the SAP. So this is one more sleeve what we have designed is called not me, of course, Kugel sleeve. Kugel sleeve is around, it is up to 16 to 18 mm size. So it can be helping after finishing of the discectomy, after dilator sequential dilatation, this sleeve prevents the nerve injury and you can happily pass on the cage. So this is how the cage is introduced. So it is the cage, we have an endo cage glider with a hitter on it. So you can fix it from the scope. Under visualization, you can see this cage going in, and you can also transverse the cage because we can hit it. The endo cage glider has a strong hump where you can use the hammer also. So this is one endoscopic funnel where after doing SAP resection and after you want to fill the yellow graft into the disc space for good functional and fusion. Because as professor was saying, sometimes we can't put bigger cages in monoportal fusion. We can't put, as Dr. Anand was saying, we can't put banana cage because turning of the cage is little trouble. So these stuff we try to manage by filling with good bone graft and filling with a cage. So that is the extra edge we have here. So this is how the rasper goes in. This is a fluoroscopic image. It's a case of 2-level fusion done 8 years back, and the patient developed adjacent segment degeneration with listhesis. So the L3, L4 I try to do fusion. So this is how after staining the disc, you can just use the interlaminar reamers to do the end plates. This is a sawbone model how we do the reaming. So this is the beauty of end plates, what we see. You can see the ALL, you can see how well we prepare the end plates. A good end plate preparation is always a good bed for fusion. So this is the case where already the patient has been undergone. So we have done again fusion for the next level. So you can see the ipsilateral traversing route, you can see the PLL, you can see the disc space, you can see the cage going in very perfectly. And also I knocked out the facet. So of course the skin incision of endoscopic TLF is smaller. Sometimes the endoscope is under local anesthesia. So of course end plate preparation is the main criteria. So these are the tips and pitfalls which I wanted to give you so that to have a good fusion. So these are the few cases what I have done. So you can see that the cages go, sometimes the bullet cage looks smaller, but making the cage transverse, and if you are able to achieve more than 30 to 40% of fusion bed, if you give good rest for 6 weeks, the fusion is adequately acceptable because anterior lordosis is the highest weight bearing part of the spine. So if you can put the cage in good anterior space and you prevent lordotic curvature with fusion, I think the outcomes are quite similar with bigger cages. Personally, these are the special instruments which we have designed by ourselves. These are endoscopic raspers and endoscopic dummy cages. So we just use the rasper with the endoscopic assisted under visualization. We use it, we prepare the end plates and we do the sizing, and then we have multiple dilators through which we push the cage. You can see the cage is transverse and center. So this is the usage of Kegel sleeve. After finishing the dilator, that is the cage glider for the screw, for the putting the cage. After you prepare the end plates, so you can see such a beautiful end plates and you can see the cage going in very well. So these are other few cases what we have done with multi-level segmental instability with listhesis, 4 or 5 cases. First how we put the cage, then how we put the screws. So I just wanted to present 5 cases, 6 cases of my life journey from starting as a basic interlaminar PSLD surgeon, then to the cases of difficult. So the advantage of interlaminar is you can see is good visualization. You can see the cranial lamina, you can see the traversing route, you can see the bulge of the disc which is very much visible, which is pressing the nerve root. So from where we have started. Next, we started with discectomies and over the top decompression. And the last one, what you see is I tried to use one more port in the opposite foramen so that to do for foraminal decompression in the contralateral. Before contralateral expertise was not there, I tried to use this technique, see through the interlaminar axis and do the contralateral discectomies. So obesity, yes, it's my favorite. Most of the open surgeons don't accept it, so I take up obese patients. The highest obese patient we have taken up is 197 kilos, so there is no problem. Just after the position, it is always the same. You can see the visualization is the same. The disc herniation is a calcified disc. The herniation is same, the anatomy is the same. So obesity is a good thing for even for fusion. Good visualization makes it. So it's like a over the top central canal decompression. You can see the traversing route and also the contralateral side and everything. This is how my journey of cases started, from decompression, discectomies to over the top decompressions. So this is the one more advantage. Before multi-level segmental, it was tough thing. Now we do something called jumping technique. We do L3, L4 level, just walk over the lamina and see the next level. So one incision, we can go up to 3 levels without destroying much of the lamina. So it's almost done. So this is a case of fusion. This is how the patient walked back immediately. This is the amount of the cage which I put. There is no much of substance. That's a post-op X-ray after 6 months. You can see beautifully the cage is pinceted below the traversing root and very much visible. It's a grade D spondylolisthesis. What I did was, I didn't show it. I did bilateral facectomy with 2 incisions. Then I started putting the screws, get good distraction and compression, then put the cage. So grade 3, which was a contraindication, yes, we have taken it up. This is a regular case of alpha S1 fusion. Alpha S1 fusion looks little tough, but I think I'll show you the disc base is quite below. As you can see below, there is a cage going in down. You can see it. Hope you appreciate it. It's quite deep. And the patient walks back immediately. Next is, I started doing with posterior cervical discectomies, foraminal discs, foraminal stenosis, then focal segmental stenosis. Then slowly I picked up, and now for cervical myelopathy, my preference of choice is conventional hemilaminotomy with bilateral decompression. You can see I started doing decompression from C4, C5, C5, C6 and C6, C7. 3 levels decompression is possible with a single port incision. So my complications, of course, discitis is a bad complication. The incidence in interlaminar root is comparatively very much, as Dr. Anand Kavi sir told, because we don't meddle much of the disc, but it's a complication. And of course, dural tears, unmanaged dural tears end up with pseudomeningocele. But intraoperative visualization, of course, we have methods to deal with it. So personal experience we have done, it's my personal experience of multiple cases of 1040 cases, of which are a fusion, discectomies and everything. So patients were doing fine. I had 4 cases of recurrence, 3 cases of dural tear and 1 case of discitis. Thank you.
Thank you very much for your nice presentation. So, okay, please.
Do you have experience of pseudomeningocele with paraplegia? I was consulted by my friend and saw the MRI just like yours, pseudomeningocele, but the motoric of the patients is reduced to from 5 to 5, become 2 per 5. It is 10 days after the surgery. Can you how you treat this kind of patients?
See, mostly in the good visualization we have during the surgery, definitely we diagnose, we find out the dural tears intraoperatively, mostly. But sometimes some kind of lateral tears, which we feel it's not a big tear or which is managed with a Duragen patch or a Tacocil with rootlet herniation, definitely they tend to be going into pseudomeningocele. So my perspective of dural tears, if there is no rootlet herniation, it is less. There is a paper by Hyun Sing Kim. If it is the square area is the area of the tear is less than 1 centimeter square area, you can just manage it conservatively, or you can just give an epidural blood patch. But pseudomeningocele is the rarest complication after dural tear. It doesn't mean all dural tears end up with pseudomeningocele. Pseudomeningocele is the worst complication we see after dural tear. But most of the dural tears, only patients complain of post-operative headache or some kind of leak from the wound, which can be managed in a different way. Which, not managed properly, there may be no leak, you feel it is contained, follow-up, the patient complains of some amount of headache and visual problems. So this follow-up MRI gave me pseudomeningocele. Being from orthopedics, I try to call my neurosurgeon to open it up and take care of it. Mostly pseudomeningocele complication, still we can't approach with endoscope. definitely it is an open surgery, because entangling of the nerve roots is also very important to prevent recurrence. But still, in endoscope, it is possible with a good patch. Take out all the contents, put the rootlet inside and put a patch.
So very impressive lecture, thank you. And I have one question, especially at L5-S1 level is no problem, L4-5 and 3-4 level. If in case of a revision surgery, or if we need to retract the root, can you retract? Can you use retraction?
So
in the monoportal endoscopic surgery?
Retraction criteria for higher lumbar levels is, of course, tolerability is less compared to the L5-S1 or L4-L5. So what we try to do is, the bony resection visualization is good enough, so we try to keep it to the minimal side, the retraction part. So yeah, that's what. Up to L3, L4, retraction is acceptable. Above that, we don't retract. So we just try to be more transverse.
Okay, thank you very much, everyone. Okay, we can close this session. We don't have enough time. If you have any more questions, just let's discuss about in the coffee break session. Thank you very much, everyone.
in the very historic city. I think that this conference is also very historical. So we are in the part of history in the spine endoscopy. So we will remember this great meeting. So I am Dr. Yang from Korea. So I moderated the last session. I want to introduce first speaker, Dr. Hikmet Sabunkoglu from Turkey. His topic is uniportal interlaminar full endoscopic lumbar decompression in the light of anatomical landmark. Please.
Thank you very much. Can we turn the, yes. Thank you very much. My name is Hakan Sabuncuoğlu, but there was wrong on the paper, but Hikmet Ulu is my teacher. It's an honor for me to hear his name here. First of all, I want to thank the organizing committee to invite me for this conference, and I can say that this conference, this meeting, is one of the most well-organized meeting in recent years about endoscopic stenoscopic surgery. Thanks a lot again. My topic is interlaminar uniportal full endoscopic lumbar decompression. Doesn't go in. Yes. We know that there are many surgical methods in lumbar spinal stenosis, but interlaminar uniportal full endoscopic lumbar decompression is a topic for today. And as you know, systematic review and the meta-analysis are the most powerful papers in evidence-based medicine. In last 5 years, highly more uniportal and biportal endoscopic evidence-based papers have started to be published in high-impact journal. And in these papers, mostly of these papers tells us endoscopic technique is at least as effective as open surgery in lumbar spinal stenosis, and also they tell extra additional good effects of the lumbar spinal stenosis, like less postoperative pain, significantly less hospital stay, and less blood flow. When we look at the indications of the lumbar spinal stenosis, we see that non-response to physical and medical treatment and algologic applications, back and leg pain limits normal activity or impairs quality of life, progressive neurologic deficit, loss of normal bowel and bladder functions, difficulty standing or walking, 1 to 3 level. It's due to my experience. I don't do over 3 level in lumbar spinal stenosis surgery, central and lateral recess stenosis. Is there any contraindication in lumbar spinal stenosis with endoscopic surgery? Grade 1 spondylolisthesis is a not exact contraindication if there is no dynamic instability on hyperflexion and hyperextension graphies in X-rays. And the important thing for success is the endoscopic anatomic landmarks for decompression. At the cranial part, thinning point of the ligamentum flavum. At the caudal part, top margin of the lower lamina and end point of the deep layer of the ligamentum flavum. And the medial side, central gap between both ligamentum flavum, midpoint of the spinous process, and contralateral spino-laminar junction. At the lateral part, lateral recess junction is the main anatomic landmarks. When we are OR at the beginning of the surgery, the initially AP radiograph is very important. We should see the end place of both vertebrae as a single line at the operation level. The spinous processes should be in the midline, and the interlaminar space should be adjusted between the both spinous processes. This one is the upper part, the third view is very important. If interlaminar space is not between the spinous processes. In AP graph, you can have difficulty during the surgery. And then in the AP-graphy, we mentioned the level, and then we again plan the craniocaudal angle at lateral X-ray. Then we put the working cannula and we start the operation. Before my video, I want to show some static views of the anatomic landmarks. At the beginning, we see the paraspinal muscle. Then we see the ligamentum flavum. After cutting the superficial layer of the ligamentum flavum, at the bottom we will see the deep layer of the ligamentum flavum. This is very important. You know that in the spinal stenosis, thecal sac is going back, and when you reach the deep layer of the ligamentum flavum, you should carefully use the scissor. And after cutting the deep layer, we will see the epidural area. Mostly we will face with the epidural fat tissue first, then after resection of the epidural fat tissue, we will see the peridural membrane, but mostly we didn't care the peridural membrane during the surgery. But if you look carefully, you can see that there is a very, very thin layer over the dura. After this, we will see the thecal sac, and on the ipsilateral side, we will see the lateral border of the root, and when we push it with the retractor to the medial, we will see the PLL, and we will see the protrusion. And after resection of the medial facet joint, we will see the lateral border of the thecal sac, axilla, and ipsilateral border of the nerve root. And also we will see the axillary area at ipsilateral side. When we pass over the contralateral side, we will see the contralateral side of the thecal sac. We will see we will see the compressed root, and you will see with the asterisk there is a bone there. After resection of this bone, it is a medial facet joint. We will see the contralateral nerve root, shoulder of the contralateral nerve root. We will see the axillary area and contralateral side of the dura. In full endoscopic decompression of the lumbar stenosis, we will drill the upper vertebra inferior part. The thinning of the ligamentum flavum, if you see the thinning of the ligamentum flavum, I mean the deep layer, it's enough. We will drill the ipsilateral facet joint, superior articular, medial part of the superior articular facet. We will drill the lower vertebrates upper part, and we will drill the contralateral part of the facet joint. And especially at lower vertebrae, you should drill the upper part of the lower vertebra very well, and you should see and resect the deep layer of the ligamentum flavum there. If you don't, in MRI, you will see that the compression is not enough for the lumbar stenosis. This is a very important trick. In my case video, she is a 64 years old female, and she has neurogenic claudication, and there is no neurologic deficit, and in bilateral leg she has dysesthesia. And you will see the L4, L5 lumbar stenosis, and the stenosis classification is a severe stenosis. At the beginning of the surgery now, we will see the fat tissue between the muscle fibers, and we will see the ligamentum flavum. You should see the anatomic parts over the left corner, and I drill the upper part of the lower vertebrae, and then I will pass through to ipsilateral facet joint now. You will, yes, I passed through the lateral part of the ipsilateral facet joint, then I will pass to ipsilateral upper vertebrae inferior part. Then I will pass now here is the in asterix you saw the ipsilateral part of the medial facet. Then I cut the ligamentum flavum. In some cases, I use first ipsilateral decompression, then I pass the contralateral part. Then, in this case, now I will open the ipsilateral part. I will now solve the epidural area. I check the epidural area with the hook because it's a severe stenosis. I try to dissect the area between the ligamentum flavum and the posterior part of the thecal sac. I solve the fat tissue. Now I cut the ligamentum flavum. You can use piecemeal technique, or you can use only one resection of the ligamentum flavum. It depends on your skill and your hospital instrumental park. But I use piecemeal resection of the ligamentum flavum because I feel myself more secure in this technique. Now I try to open the lateral part of the foraminal area. I drilled, now I solve the lateral part of the thecal sac. Now I am on nerve root. Now I will see the axilla. Here is the axillary area of the ipsilateral part. And now this is the L5 nerve root. Also I solve the lateral part of the ipsilateral part of the nerve root. Now I pass the contralateral side. Now I drill the upper part of the lower vertebrae with diamond drill. After that I will solve the contralateral part of the thecal sac. Now I will show something. This is not a nerve root. This is the part of the ligamentum flavum over the superior articular facet. Here is the thecal sac border, and here is the asterix is the ligamentum flavum. Maybe we can have a confusion initially at this point. We should be careful, and we will we opened the contralateral nerve root, L5 nerve root. I checked the mobility of the contralateral nerve root with hook. It's very soft. And also I checked the axillary part of the nerve root. Then I will again check the contralateral side and ipsilateral side together. Here is the ipsilateral nerve root, axilla, thecal sac, contralateral nerve root, axilla, and the lateral borders. You should, every lumbar spinal stenosis surgery, you should see this view, because also you should see the CSF pulsation, and you should see the thecal sac and both ipsilateral and contralateral nerve roots. What should be pay attention during the surgery? The approach and bone decompression may be difficult in cases with the spondylotic changes such as severe facet hypertrophy and scoliosis. The success of surgery depends on the preoperative planning of the surgical corridor and clear identification of the target area and seeing the lateral borders of all neural elements. Choosing too steep and the rostrocaudal approach angle in cases of especially upper level narrow canal prevents the decompression of the caudal aspect of the stenosis as the endoscope is deflected by the caudal lamina. In patients with congenitally narrow spinal canal, the use of smaller endoscopes facilitates the visualization of the ipsilateral facet joint, can interfere with the image obtained with larger endoscopes. However, smaller interlaminar endoscopes were fragile, more fragile, less effective for bone and soft tissue resection, and more susceptible for the bleeding. Steep-angled or small laminas, hypertrophied lateral protuberance of the spinous process inhibits the laminas exposure. In these cases, more medial skin incision and endoscopy landing medial to the lateral tilting of the endoscope is necessary. If there is a, here is you see the protuberance at S1 level. There is a left protuberance of the spinous process. If this process is L5, maybe you can have a difficulty to put your endoscope working cannula to the correct part. And AP and lateral direct radiographs should be taken whenever you feel unsafe or disoriented during the surgery. If you have any doubt or if you have any confusion, every time you should use the AP-graphy during the surgery. If there is a problem in identifying the ligamentum flavum, it's possible to work too close to either the facet joint or the spinous process. It should be checked with the direct radiograph. Initially, at the beginning of your surgery, your primary landmarks are the superior laminans inferior or inferior ipsilateral lamina, part of the superior, or facet capsule. In very narrow canal of partially upward levels, there may be a problem in identifying the contralateral ligamentum flavum, and it may be mistaken for a thecal sac or nerve root. It is appropriate to see the CSF pulsation during the surgery. Thanks for your attention.
Thank you. Good presentation. Do you have any question in the floor? Okay. Where is the microphone?
It's a wonderful presentation. So my field of usage of Richard Wolf interlaminar scope, you are using a scope which is 25 degrees angulation. Am I right, sir?
Yes.
So do you feel that it is good for contralateral, but ipsilateral you try to destroy more of facet?
Yes, you are correct. We can use the lumbar stenosis camera during the surgery, but I didn't have any difficulty with this angle in this case.
I feel more the angulation, doing ipsilateral is more tough than doing the contralateral. You try to remove more of the facet.
You mean that I did more facet resection at the ipsilateral side?
Yeah.
I don't think so, because how can you give this decision?
Because of the angulation, 25 degrees.
Angulation, okay.
Thank you. Any more questions? And so I got a question.
Sorry, I think angulation doesn't hamper the facet, excessive facet resection. Angulation will make difficult to remove ipsilateral facet because of we work more 25 degree. We work more on contralateral side, but you have to rotate the scope on our side. So when you rotate, then it is not a problem.
In this case, I didn't go too forward to my side. My criteria in lumbar spinal stenosis, every time I should try to see the shoulder of the nerve root. If you don't see the shoulder of the nerve root, and only if you see the lateral border of the thecal sac or axilla, I think that it is not good decompression. This is my opinion.
Okay, thank you, doctor. Thank you for a good presentation. And I got a news that on live surgery is being prepared from Dr. Lim. So, Dr. Elmo, you should wait more for your presentation. So we will prepare live surgery from Dr. Lim. Can you start connections?
Hurmatli qatnashchilar, hozir bizda live surgery boshlanyapti. Doktor Lim hozir MRTlarni ko'rsatib, hammasini tushuntirib beradilar. Nima bo'lishi, qanaqa
Table down.
boshlanadi. Online bog'langan yaqin.
Okay, Dr. Lim.
Sir, you don't need anymore?
We are watching you now. So, did you start your operation?
Okay.
Dr. Lim, can you hear me?
Mana buni qiyshaytirsa bo'ladimi? Yo, to'xta, mana buni qiyshaytiramiz.
Okay, I think still the endoscope is not introduced to target.
Emas, mana bunaqasiga qish. Do you need one more shot?
No, it's and he is checking the level and location of endoscope now.
Yeah, like this.
So this is the very beginning of the operation.
Finish it all?
Sir, just one shot.
Lecture? Okay.
You know that this is the rival surgery in the new hospital, so
you will explain.
Everything will want to go straight.
Ko'tarolma.
Hello, can you hear me? Can you hear me?
So we are looking around the operation room.
Can you hear me? Hello?
Yes, we can hear.
Hello?
Okay. Yes, Dr. Lim, we can hear you.
Yes, Dr. Lim, we can hear you. Okay. So, I will try the endoscopic compression. For patient have a right side, the leg pain, the dermatome is L5 dermatome. MRI shows L4534 two level bilateral stenosis, central stenosis, and the patient have a right side primary stenosis. That's why I try to the left approach, left L45 approach. I try to bilateral decompression and the contralateral approach, foraminal decompression, and then jumping up to the 3-4, I try to bilateral decompression. That's why with the one skin pole, I try to 4-5 bilateral, and then contralateral side, foraminal jumping up to bilateral. So I try to 5 root decompression with the one skin pole.
All right, thank you, Dr. Lim. So let me repeat. The patient has L5 right side pain.
Yes, right side.
And then central stenosis, L45 and L5S1.
No, L4534.
Ah, okay. So you will do a left-sided approach.
Yeah.
And
left-sided approach.
Answer the stenosis from the left, ULBD, and go to the contralateral side.
Yes.
All right. Thank you.
All right. And then jumping up to L34, and then I will try to the ULBD, bilateral decompression.
Okay. So the problem is 3445.
3445. Yes, 3445.
Thank you.
Okay. Thank you. Okay, I will start. And first, I'll try to jump check. The L45 first. Okay. L45 jump check. Okay. We don't need to check AP view, only lateral view, because the landing point is just beside the spinal process, right?
Нам достаточно только боковой проекции, так как точка лендинга, то есть точка контакта, проходит рядом с остистым отростком.
So Dr. Lim is now cutting through the skin, 7 mm incision down to the fascia,
Sham check. Okay.
and docking in the spinolaminar junction of L45.
Right.
Let us check. Something went wrong. Look.
Okay. Sham check. Okay.
So?
And table down. Table down. Okay. It's L45 first. Table down.
It's It's in the cranial lamina, Dr. Lim.
This one. Bunu to'g'irlagan serum. 1 second, sir.
Okay. Yeah. Okay. Good. Water. Water, please.
Soup.
Soup. Soup. Okay. Proceed. Proceed. So first, we need to find the lateral, spinal laminar junction, right? It's a spinal laminar junction. We can feel the texture. It's a laminar spinal laminar junction, right? And then punch.
Нам сначала нужно найти спиноламинарный junction, то есть переход спинального отростка, осистого отростка в
spinal
ламину.
laminar junction here, right? Spinal laminar junction. So with the first the bite of caris punch or the spinal laminar junction, you can make a 3D image in my mind. The spinal canal direction is this way, right? This way. That's why I try to drill or caris punch using drill punch to reach the uppermost ligament flavor this way. Drill.
Так, первое выкусывание производится в спиноламинарной как бы смежном участке.
This way, right?
И обработка дрелью производится в направлении с верхнего прикрепления желтого отростка.
It's a 12 o'clock. It's a spinous process, and it's laminar. And 6 o'clock is a fascia joint. Main purpose of endoscope surgery could be the pressure, the fascia joint.
12 часов это остеотросток, 6
First,
часов
we have to
это
reach
фасет
to
6.
uppermost ligament flavor.
Сейчас нам первая цель это достичь краниального прикрепления желтой связки.
So take notice of the hand of Dr. Lim while he's putting inside the drill. So the finger is used as a stopper. He can put it very fast inside without very safe.
High speed drill. How is the drill speed?
20,000.
20,000.
So that's 20,000 RPM now.
Okay. High speed drill. Yeah. Okay. Okay, I will check the inside bipolar. You can see inside the ligament flavor, right? Ligament flavor. But it's not enough. I try to more drill.
It's very tight.
Increase the drill speed.
So he did the laminar.
Okay.
Okay. So for our audience, this is the MRI of our patient.
Thank you. Good. Yeah. I like it.
So in the endoscopic view, in the 9 o'clock is cranial, in the 3 o'clock is caudal.
3 o'clock is laminar.
9 часов это ламина, 9 o'clock.
9 o'clock is laminar.
Yes.
3 o'clock is the caudal part.
3 часа это каудальная часть.
Off the right.
Свет, черный.
The size of a burr is 3.7.
Size of burr?
Size of burr.
3.7?
3.7.
It's a diamond burr.
Размер алмазного бура 3,7 миллиметров.
Okay, proceed. So you can see inside the ligand flavor. So first we have to reach the uppermost ligand flavor.
Так, нам нужно достичь самой верхней точки прикрепления желтой связки, краниальной, самой краниальной точки.
So now we can see ligand flavor after laminectomy.
Yeah, yeah.
Okay.
Yeah.
The left side is cranial.
Yes.
Yes, left side is cranial.
And
right side is
now,
caudal.
yeah.
Wow, this is the male patient have a strong bone. So strong.
You're stronger,
Yes,
Dr.
nose
Lim.
also
You
is-
can see
yes.
you can see here the uppermost ligand flavor, right? Just
Okay.
30
Dr. Lim is trying
is
to
enough to reach
detach the attachment to the cranial lamina. Attachment of the ligamentum flavum of the into the cranial lamina. Superior attachment, yes.
4 millimeters, much 4.
So that's a bigger, and this.
Yeah.
Okay.
4 millimeter Carison punch.
4 millimeter Carison.
Yeah. Okay, not enough. I'll try to more. Drill. Narrow space.
The bone is tough.
Using the drill ball, it's where is the camera? So we can use the
Finger.
the finger will act as a stopper, right?
Yes.
Like this. Do not use a drill like this.
Oh,
Danger,
yes.
right? Or else this finger will act as a stopper. Right? With the side ball, from the outside inside, outer inside, right? I can touch I can feel the soft ligand from inside. That's what I can do, right?
So you are shaking the drill to faster laminectomy and drilling.
And then, okay. There is a punch. 4. Water. Okay.
We can now see some pulsation in the ligamentum
How
flavum.
is the blood pressure? Okay. Drill. Water. Water is okay.
Irrigation.
Okay. Water. Water is not working. Okay. Punch. Go. So without water pump.
Dr. Lim, are you using gravity for irrigation or pump?
It's not working. Water. Okay.
Is that gravity?
Can you increase? The water problem. Drill. Drill. Punch. 4 millimeter punch. 4 millimeter. 4. Oh, the water is not working. Why?
There is because this only one port water irrigation. We should Scope. change scope.
Change scope?
Yes. If you want, we can change scope.
Why?
Because only one port. Камера стерильный, конечно, она что?
Okay, I will. And how about you? You.
I think best is change scope.
Okay, I will change the scope.
Aytmoqchiman, ichkaridagi kamera sterilniku demoqchiman.
I think he has some water drain issues.
At this point, we notice some bleeding. It's because of the poor irrigation pressure. Dr. Lim, you're changing scope.
Да, из-за проблемы с давлением ирригации пришлось поменять скоб. Сейчас. Так как мы используем естественную гравитацию для ирригации, поэтому у нас давление ирригационного физраствора.
Irrigation tubing is very small, but there's 2 of them now.
So in the live surgery, everything is happened.
Okay. Okay, water. I think the line.
Yeah, heavy line.
Our diameter is too small.
Yeah, we need a bigger tubing.
If the tool we use is can give it enough pressure.
Bundan ham oqyaptimi?
We can use
bundan ham oqyaptimi? Ikkitasidan oqyapti deyman.
Dr. Lim, we can elevate the saline some more.
How's better, да? Да, лучше. Да. Вот теперь, да, намного лучше.
Ipsilateral.
So he's doing the lateral laminectomy.
Okay. So 4 millimeter tracer punch. 4.
Okay. Okay, I can see some clearance of the attachment.
can see uppermost ligand flavor.
So that's the door to
Вот мы
the
приблизились
epidural
к
space.
краниальной точке прикрепления желтой связки.
Epidural space.
So that is in the 11 o'clock. You can see the thinning point of ligament flavum.
Okay. It's uppermost ligand flavor. Okay. Turning.
And detaching.
It's very thick.
Detaching, yes. Okay, that's ligand flavor. And the endoscope you can turn like this to know under the ligand flavor. Is there no any problem?
Можно повернуть эндоскоп,
Okay.
сделать поворот и увидеть, если спайки или нет.
Lifting the ligamentum flavum can make you take a look under the flavum and into the dura.
Oh, moving the patient.
عمل improve it.
Very thick ligand flavor. Uh-huh.
No, I don't think so.
And to other part.
You can notice that the lateral side has no fat in the epidural space. That's where the stenosis is more located. In the medial part, you can see lots of epidural fat.
You can see the lateral margin of dura here. Okay.
Можно увидеть латеральный край дуры.
We are now in the lateral, ipsilateral. Yeah, it's really That's a lateral recess, ipsilateral lateral recess.
Yeah. It's chronic stenosis. The dura looks like the balloon. So I try to bipolar duroplasty.
Из-за хронического стеноза дуральный мешок выглядит как шар, раздувающийся шар. Сейчас дуропластика будет проведена с помощью радиочастотного абляторов.
It's partly duroplasty, applying heat on the dura because it's called a redundant dura. After a so long compression, the dura will become redundant.
Dissector.
Junction. Now also we can see a part of the L5.
Confirm it's right? Lateral margin of dura, right?
So that's the lateral recess, Dr. Lim.
Yeah, it's the annulus. It's the lateral margin of dura, right? Punch. Go. Okay, lateral loop decompression.
rotation of endoscope.
I don't know exactly. Punch
Фиброзное кольцо мы
2
увидели.
millimeter punch. This for the shoulder.
Так.
Drill. Endoscope is different. Drill. Drill.
Это другой эндоскоп.
Oh, it's not working. Drill. Drill is not working.
Kindly check the attachment. All right, it's
Okay.
working now.
Okay. Punch 2.
Yes, that is
You
lateral
can notice that
junction.
Dr. Lim rotated the camera and the scope. So you can now see more lateral and more cranial.
Okay. Okay. 4 millimeters punch.
Dr. Lim is now removing the caudal ligamentum flavum.
Caudal. Yes.
So to decompress the traversing root.
So if lateral laminectomy is usually finished, is after lateral approach, he is doing some of lateral decompression and caudal decompression.
He knows, it's very familiar territory.
Okay. Bipolar.
We know that his endoscope is always moving, doesn't fix in one direction and one location, always move, rotate. That is a master.
Yes, this is annuloplasty, Dr. Lim.
Yeah. Yeah. Dissector.
That's the ipsilateral disc.
Yes. Yes. Annular plus. Yes. Annulus is root. But it's not enough. Okay. Drill. It's not enough. I'll try to more. Lateral decompression.
Okay.
Ablatsiya risk düşecekleri. Biz var. Ablatsiya şunun ablatsiyasi.
That's kisser. Oh, it's not working. It's not working. Punch 2.
Drill.
There.
Oh.
Biraz doktori. Ayollarına yapalım. Üçün üşeme. Koyun koyun. Ya koyup durayım. Hamas bitsin ki ertesi.
Okay. Drill. It's the drill.
So you want to do more foraminotomy?
Tipo de glana.
Dr. Lim will now
Strong
drill
one,
part
patient
of
there.
the SAP.
Кости очень твердые, поэтому
Okay.
часто приходится
Кончится.
использовать дрель.
It's medical area.
Dr. Lim,
Yes.
we will continue with our lectures. We will, from time to time, we will get back to you. Is that okay?
Okay. Mm-hmm.
All right.
Dr. Ijam, you want to continue lecture, right?
Yes, yes.
Yeah. Fusion.
Okay. Okay, sir.
I'm not sure.
Not yet. Not yet sufficient.
So
It's
after
extra portion here.
Okay. After finishing the ipsilateral decompression, can you
Drill.
explain the anatomical location and some structures for us?
It's a caudal part. It's a 4 mm cane sponge. Oh. It's very strong bone patient has. It's extra portion. Okay. What's it? Do I need to lecture? Dissector? Bipolar? Yesterday I told about fusion surgery already. Okay, stop. Dissector? No. I don't need. Okay, it's a lateral marginal root. It's the extra portion here. It's a pedicle area. Okay. 2 mm punch. 2.
All right. That was the ipsilateral decompression, and Dr. Lim will be going to the contralateral in a while. So, but we have to finish the lectures. I know it's very interesting, but I'll be quick with my lecture. Thank you.
So we are coming back to the session. So now we start again. The second speaker is Dr. Elmer Joseph Meseda. His topic is endoscopic management of symptomatic Bartolotti syndrome. Please.
Thank you very much, Mr. Chairman. Pardon with my earlier presentation, our chairman earlier, Dr. And Dr. Haiti, because of the confusion.
the topic now is I'm the one going to present. So I'll go direct to the case. This is a 63-year-old male, non-diabetic, non-hypertensive. Long history of back pain, 30 years, 10 years, persistent low back pain, progressive. Did a lot of, management, went to a lot of doctors and other means to relieve the back pain. Is near depressed, had a depression, separated from the wife and the family. After 2 years prior to admission, the patient had worsening low back pain, had an incidence of fall, went to several spine doctors and was advised for surgery. The surgery advised was a fusion surgery of L4-5, but the patient did not consent. At that 2 years prior to admission, he also noted a right L5 radiculopathy with intermittent symptoms. He underwent rehab and physical therapy with failure. 8 months prior to admission, he had an emergency and he has to go abroad to look after his daughter in the US. But he had a problem. How can he take care of his daughter who's in the hospital in the US if he has that back pain? So he convinced me to give a transforaminal epidural block. At this time, I already had the patient's CT scan, lumbar CT scan. So you can remember low back pain, long time, on and off, depression, and then 2 years started to have radiating pain, radiculopathy to the left, L5 dermatome. Almost normal patient. The right anterior and lateral leg pain is muscular. It is described as, have you tried running without any exercise, running a marathon or 5-10 kilometers without preparation? The next day your muscles will ache. So this is the ache that he's experiencing. The CT scan of our patient, this is the left side. You can see a wide foramen, but on the right side, you can barely see half of the foramen. And this is the patient's CT scan. You can see the transverse process on the right side is arthrosed or attached with the sacral ala. And another view here in the axial cut. I measured this plastic transverse process is 23 millimeters. This positioning, from the midline, that is the measurement for my docking. And this is the measurement for my antero-posterior decompression. This is the measurement at the lower border of the transverse process. What is known about lumbosacral, transitional vertebra, and Bartholoti syndrome? Some would say it's just 4%, but many literature would say it's 36% incidence. It's a congenital problem. If it's congenital problem, why then will our patients develop symptoms at the 4th and 5th decade of life? It is because the physiology and the mechanism of fusion will allow hypomobility on that L5S1 level, and then adjacent segment will have a problem. Also, some arthrosis or arthritis, osteoarthritis, can affect and make compression on the exiting nerve root. It presents as lower back pain on the 3rd and 4th decade. The formation of the transitional vertebra may cause nerve compression. And patients who have Bartholot's syndrome tend to have a more significant spinal degeneration above the deformity than the other conditions leading to chronic back pain. This is a classification of the Bartholot's syndrome according to Castelvi, and our patient is the type 2 classification. Type 2A is ipsilateral incomplete lumbarization, sacralization of the transverse process. What causes pain in Bartholot's syndrome? Some say, and literature say, that it's pseudoarthrosis. The pseudo joint between the transverse process and the ala causes the pain. Some would say compression of the exiting L5 nerve and other confounding pain triggers because of the degenerative findings, especially if an MRI is taken. So what are the treatment options? So first, we have to do medical management and pain management, rehab, physical therapy, steroid injections, and then resection. It's prosectomy, or either partial or complete. Prosectomy is the resection of the transverse process. I don't know why they called it that, but the process removal is prosectomy. And or a decompression of the nerve root. And fusion is a questionable option. However, it has been done. So here's the pyramid of treatment from conservative to interventional and then surgical management. What I did in the patient. So this point on the right side, the patient has a right-sided radiculopathy and back pain. So I measured is 4 centimeters to the docking. This is what I wanted to find out and to see in the endoscope. So you can see the facet joint, you can see the transverse process, you can see the sacral ala, and it's very clear in the endoscopic view. That's removal of the thin layer of bone, and then identification of the junction of the sacral ala and the transverse process right there. Trying to cauterize the radicular arteries. I am now doing drilling in the posterior part of the transverse process. I did not plan to remove the whole transverse process, only the posterior part, the part that is compressing the nerve root. And I use some chisel as well. So this is drilling now of the sacral ala. And finally, we'll be able to decompress. You can see now part of the nerve root. That's the nerve root. Further drilling down, beyond, so I can see 360 decompression of the L5 nerve root. And you notice, to check for bleeding or for dural tear, I put a French 8 feeding tube and suction to make it very clear. Just like an open micro decompression like that. Okay? So this is a microscopic decompression. You can see this view. So while doing this, I asked the anesthesiologist to do Valsalva maneuver. I do that for all my procedures, even for PSLD and PSCD. So some images. This is the transverse process and the sacral ala. Started drilling on the sacral transverse process, and now drilled part of the half of the transverse process. Removing part of the ala exposes the exiting nerve root. Now we can see almost 200 degrees of the nerve root. We just have to go down a little. And now the discussion for outcomes on resolving pain in Bertolotti patients. Decompression may be the most beneficial for patients who present with nerve root symptoms, while pseudoarthrectomy or prostatectomy may show the most promise in patients whose previous treatments indicate that the pseudoarticulation is the primary source of pain. Fusion of the lumbosacral spine is controversial in these patients. It may accelerate the development of adjacent segment disease that they are already predisposed. Patient is happy. A week after the procedure, he regained his life, went back to work, and then he now does exercises regularly. Several publications about endoscopic management are already published starting 2017. This algorithm for management of Bertolotti syndrome was presented in the publication of Stein et al. Last year in 2023. They modified the algorithm presented by Almeida and Lee in 2009. So the modification is addition of the endoscopic resection or decompression. However, I would like to suggest an addition to this algorithm, and these are the arrows in red. So pain, unmanaged with no relief from conventional management, will be given steroids. And if there are no possible causes of pain, they go directly to radiofrequency ablation and operative management if there's no relief of pain. However, if there are like radicular symptoms, so no symptoms, yes, radicular symptoms, and there's improvement with the nerve block and transforaminal epidural steroid injection, patient can go to the decompression of the exiting root and related decompression of related pathoanatomical structures contributing to pain. And it can be done on one procedure. You can decompress the nerve root and then do prostatectomy. So it will not add more time and will make the patient more happy. No additional time, no additional complications. This is a very safe procedure. You can see the root pretty well. So it's like a paraspinal approach without going into the canal. So it's a very rewarding procedure. That ends my lecture. This is I would like to show this international cadaveric course in Manila we had last April. I'd like to point out the very good visualization of 82-inch camera to the participants. Training our young endoscopic surgeons will have a very big impact if they can see everything. If you have a small monitor during training, they will try to crowd in front of the monitor to see what's going on. But if it's a very big monitor, then there's no issue. Thank you for your kind attention.
Thank you, doctor. And any question from floor? Okay.
We can ask Dr. Lim.
Okay, I'll ask you one question.
Yes. Yes, you have a question?
Yeah, I got one question. This kind of treatment, always we do the extraforaminal L5 decompression. During the operation, we think that is enough. But after operation, when you check a post-operative MRI or CT, we found that the decompression is sometimes not enough. So do you have any your indication to get sufficient lateral decompression?
All right, it's important to see the 360 around the root. So that means you have undergone decompression of the top, the sacral ala in the transverse process, and then below. So if you can see below the root, then that will be enough, especially the whole extent of the root. Because beyond the root is now the iliac process. You don't have to decompress the iliac process. Some doctors and some publications would recommend doing RF on the iliac process near the transverse process. I don't do that. I just decompress and remove the pseudo articulation. Thank you.
Okay.
Dr. Nantawat.
Okay, another questions?
There's a microphone.
Hello. Okay. I think one of the difficult part of the pathology is a diagnosis.
Yes, I agree.
Yeah, and the patient maybe come with two symptoms. The first one is just a back pain, and the second one is like a root pain, like the compression, the L5 root. So in your practice, do you do some diagnostic injection before or do anything?
It's a very important part of the diagnosis. The surgery is straightforward surgery. It's very easy. The more difficult part is the diagnosing the Bartolotti syndrome. So patients who presents with long history of pain, on and off pain, cannot be relieved by anything, have tried a lot of things, you have to do a CT scan. It's in the CT scan, it will reveal a lot. So I started seeing Bartolotti cases in 2017, and I'm very conscious about getting a CT scan before advising any form of surgery. CT scan is very accessible. There's CT scan right and left, so it's not very expensive as well.
For the injection, if you how many injection you confirm it? 2?
I do first, if there's a root compression in the MRI and the CT scan, I do the root injection first. Okay. If there is 70% relief, then that means the root is contributing 70% in the pain. Then the arthrosis is contributing 30%. I ask the patient, are you going to be happy with the 70% pain relief? If the patient say yes, we do decompression, I do RF of the pseudoarthrosis. If the patient says, I want 100% pain relief, then I do injection of the pseudoarthrosis as well. However, if there is no radiculopathy symptoms, I do injection of the pseudoarticulation first.
Okay.
Thank you very much.
Thank you. Thank you.
Okay, thank you. Let's move to next presentation. Let me introduce Dr. Lavkush Pandey from India. His topic is precautions and prerequisitions to avoid the complication during PSLD, from making diagnosis till postoperative rehabilitation.
Good afternoon, everyone. I'm Dr. Lavkush from India, and this is my photo we clicked during Corona times when we were performing our surgeries in all those scrubs. My lecture is more focused on the beginners and those who started their journey in spine endoscopy. And I am associated with Dr. Satish Chandgore. He's a renowned transforaminal surgeon, and Dr. Kangtuk Lim. From him, I'm transferring their legacy to the beginners. We work more, focus more on the beginners who just started, completed their graduations and post-graduations, and we run our center in Dehradun, and we are associated with all the Indian surgeons and surgeons from the abroad who are associated with us in teaching and training programs in Dehradun for last 7-8 years. So my topic is just how to precautions and prerequisites for avoiding the complications during PSLD. PSLD is just stenotic lumbar decompression is the delicate procedure that requires careful planning and executions to avoid the complication. Here are some precautions and strategies to help minimize the risk of complications during the procedure. What I follow, these are the few criteria which I really follow in all my patients. First, started with the patient selection, pre-operative assessment, surgical planning, and the equipment and technique, team expertise, informed consent, anesthesia management, intraoperative monitoring, surgical technique, post-operative care, and follow-up the patients. So patient selections is the first primary criteria to perform any kind of surgical procedures prior. Ensure the patient is carefully selected based on their medical history, the patient is how long the symptoms and durations, radiculopathy, claudications, detailed examination of the patient, and imaging studies to support your symptoms and diagnosis, overall health of the patients, any comorbidities like hypertension, diabetes, other symptom disorders, and any kind of contraindications for the endoscopy like red flag signs and any higher risk of complications in those patients. And the contraindications for stenotic decompression is depend for the expertise of the patient. In earlier phase of your life, there will be many contraindications, but once you expertise your technique, then you can easily cross those contraindications. Generally, for the beginners, the main contraindications like red flag signs like tumor, metastasis, infections, spondylolisthesis where we need a fixation, although severe and central canal stenosis where you're not able to handle those cases, patient having mild to moderate just back pain and multiple level of stenosis, patient having a previous surgery and you go for the redo surgeries and Kodai-Kuna syndromes. So these are the earlier contraindications for the some beginners. The pre-operative assessment prior to go for the surgery to conduct a thorough pre-operative assessment including the detailed neurological examination, review imaging studies like MRI, CT scans, X-rays, and accurate identify the location and extent of the stenosis because you are going to treat the patient, not the MRI and radiological images. Correlation of those images with the symptoms of the patients. If you need any diagnostic kind of blocks, if you are not confirmed, there are 2 levels of stenosis, the patient having a symptom of both the levels or having the single level of the surgery, then you can go for the root blocks, nerve blocks. So confirm your extent of the surgery. The surgical planning, because you are a beginner, you are starting for your first cases. So plan surgical approach based on specific anatomy and pathology of the stenosis in the spinal canal, varying from patient to patient. Use of advanced imaging techniques such as 3D reconstructions to visualize the surgical sites and surrounding structures. Always keep plan B in your mind. If you're not able to access into the foramen or into the interlumen canal, then what will be the next step? Because you are a beginner, you are doing your first case. And teamwork always work. Back up your senior surgeons or in your department or any of your friend in a city that you are performing a case. If you are just stuck with the case, then you can ask your friends to help you out. And the equipment and technique, equipment and instruments are your best friend. So always use high quality endoscopic equipments, instruments suitable for the procedure. There are many international brands. You already seen those stalls on the stalls. They are showcasing their products. Substandard instruments will not help doing you the right job, and ensure that the endoscope and other tools are properly sterilized and maintained by your staff. And the team expertise have a skilled, experienced surgical team that is familiar with your endoscopic technique and the instrument for the lumbar canal decompressions. Collaboration with your neurosurgeons. If you are an orthopedic surgeon, then you can collaborate with your fellow colleagues like neurosurgeons, orthopedic surgeons, and intervention radiologists that can improve your outcome in your early stages of cases. And your paramedical staff should also be well trained for handling those cases during the surgery. So prior to start the surgery, we just get an informed consent from the patient, explain the risk and benefits to the patient, because you are performing a case because everybody is just worried about the spinal surgeries. Customize to the patient's and overall health. If a patient doctor mentioned that the patient, if you're happy with 70% of the pain, or if you want 100% relief of the pain. So you can customize the plan according to the need of the patient. Discuss the potential complication that can happen in earlier first cases, like infections, bleeding, recurrent symptoms. You have to get the informed consent, because once you landed with the complications, then you cannot explain to the patient. You will be in the court. So anesthesia management, because you are performing first surgery or earlier cases, then your anesthetist must be aware of the technique, because what you are going to perform and under which anesthesia you are going to do surgery. Because the transforaminal surgeries and interlaminar surgeries that can also be done in local anesthesia, but anesthetists generally don't know these surgeries can be undertaken those local anesthesia. So coordinate with the experienced anesthesiologist to provide appropriate anesthesia and monitoring during the procedure. Consider the use of local anesthesia, sedation, regional anesthesia, or general anesthesia based on the patient's need and the technique, and the post-operative pain management. The intraoperative monitoring in higher setups and level 3 hospitals, generally they use electromyography and somatosensory evok potentials to monitor the numb function and detect any potential complications in the surgery. The complications generally happen, everybody knows, have already been explained, like dural tear, epidural hematoma, transients, dystocia. It depends on the expertise of the patient, and the occurrence in these complications is vary. Dural tear is not so much common, it's generally less than 1%. So dural tear, epidural hematomas, urinary retentions, motor weakness, cauda syndromes, wound infections, disc herniations, persistent pain, medical problems, IP fractures, incomplete decompression, instability, or lens instruments breakage. So these complications should always be kept in your mind. And the surgical technique already been discussed by the Dr. Hickelman and all my friends, how to enter the proper steps of the surgery. Dr. Lim sir were also explaining how to land, where to land according to the pathology of the patient. And during the surgery, always identify the structures. So employ the precise and meticulous surgical techniques to minimize the tissue trauma and avoid damage to the surrounding structures such as nerves, blood vessels, and dura mater. Identification of the tissue is more important prior to cut, coagulate, or ablate. If any confusion, leave it and do more dissections and do confirm yes prior to go for any action on those structures. And the post-operative care, once you operated the patient, and how to handle those patients, because patient is going back to home after 12 hours or 48 hours. So detailed post-operative program should be planned for every surgeon, every patient, and this varied from patient to patient and according to the surgery, because in transforaminal surgery, we generally discharge the patient after the 2 hours, but in interlaminar surgery, we generally prefer to keep the patient for at least 12 hours, and we put a drain also, because drain is always safe to give you a good sleep. So provide comprehensive post-operative care that could include pain management, monitoring of the complications, infections like hematomas, rehabilitation to promote recovery and functional improvement, and lifestyle modifications and follow-ups. Generally we do follow-ups, first follow-up around first week, then 4th week, then after 12 weeks, and then 6 months and a year. So these are the follow-up program generally I used to follow. And schedule regular follow-up visits, patient's progress, to see the patient's progress, assess outcome, address any concern and complications promptly. So I'm just sharing the one example. This patient was just operated in our hospital last, Dr. Shiraz, during my conference. So she was a lady of 78-year-old female. She was excruciating right side leg pain for 3 months. She can't sit, can't walk, and claudication was there, cannot stand, and on MRI you can see there is a stenosis over the L45 and L5S1. The disc height is low in L5S1, and in MRI and sagittal images you can easily appreciate there is a compression on the L5 nerve root as a traversing nerve root on L45 level and as an exiting nerve root at L5S1 nerve root. So this patient, so what should be the plan? Our plan was to perform stenotic surgery at L45 and L5S1 level under general anesthesia. But there were some issues because she was a known case of chronic kidney disease, coronary artery disease, hypertension, hypothyroidism, anemia, serum creatinine was 6 mg/%, hemoglobin was 9, on so many medications for last 2-3 years, and general anesthesia was the high risk. So patient was in severe pain, but these comorbidities was letting her away from the surgery, and none of surgeon was willing to perform any kind of surgery in such patient. Then we were planned for this surgery. So what could be best can be done for her? Yes, she was operated on 27th April, and the surgery was performed PSLD at L45 level and para-PCLD at L5S1 level under local anesthesia, and there's a mild sedation because we cannot use anesthetic drugs as patients' kidney problems were there and creatinine was high. So surgical time was 90 minutes, and this patient is a third post-operative day. She came to my clinic just to say thank you so much because she started walking. So the best beauty of the endoscopic surgery is that you can perform interlaminar and surgeries under local anesthesia, and your anesthetist should be well trained and easily under local, and you can put drug patient having pains, mild sedation, and continue with the surgery. So it depends how to handle your patient and what precautions and prerequisites are required for performing any kind of endoscopic surgeries. The precision, be precise. A lack of precision is dangerous when the margin of error is small. Conclusion: by following these precautions, strategies, one can help reduce the risk of complications during endoscopic stenotic lumbar canal decompression and improve the patient's outcome. So these are all the points I was concluded, and this was last meeting when Dr. Ling visited to my center, Dehradun, in teaching and training program. It was second visit, so it was the return of the endoscopic sniper in Dehradun. And these were the delegates who were attended this workshop. Last weekend we were busy with those conferences. And when somebody is on your shoulder, then your all your confidence go up, touching sky. And these are my teachers, Dr. Satish Chandgore and Dr. Lim, who gave me access through transforamen and interlaminar into the spinal canal. And miracles do happen when spirituality meets science. Dr. Lim visiting to India. Thank you so much.
Thank you, doctor. Any question from floor? Okay, yes.
I want to ask, do you have a problem in performing PSLD with local anesthesia in patient with high blood pressures? Since it will block your vision because due to the bleeding. Thank you.
Yes. In patients with high blood pressures, I generally don't do all cases in local anesthesia. Local anesthesia is generally kept for the patients where doing a surgery under general anesthesia is contraindicated. So in this patient, the BP was just in between was hiking up. Then we use anti-hypertensive like labetalol injections we were giving in small doses in between the surgery to keep the blood pressure around in two digits and increase the level of sedation also. Otherwise, I generally prefer my surgeries in epidural analgesia only. Put a epidural catheter 2 level above and give the sensory blockage like labor analgesia and perform the endoscopic surgery, because I want patient to be my best monitor than these electronic monitors. Thank you.
Thank you. Before moving to next speaker, we are quite behind the original schedule and our lunch is ready in lobby, but we cannot stop. So feel free to go to lobby and bring your food and bring back in conference room, and we will continue our our presentation during your lunch time. So I'd introduce the next speaker, Dr. Vishkan Zelika from Turkey. His topic is how can increase intracranial pressure to be prevented in spinal endoscopic surgery, fluid management in spinal endoscopy.
Можно я переведу? Мы отстаем от времени, поэтому обед готов. Если кто-то хочет покушать, может принести сюда и здесь кушать и смотреть лекции, потому что на обед останавливаться не будем. Мы уже очень позади времени. Поэтому.
Please, is presentation is not in our screen.
Good afternoon, dear President and colleagues. First of all, I would like to thank you again. Dear participants, welcome all of you. The subject of my presentation is how can increased intracranial pressure be prevented in endoscopic surgery, fluid management in spinal endoscopy. During spinal endoscopy, the purpose of using irrigation fluid by managing the hydrostatic pressure in the decompression zone, improve viewing, and is to control bleeding. Fluid management during lumbar spinal endoscopy and literature on irrigation related problems very little. Rate of undetected durotomy 1%, observed rare but serious neurological and cardiovascular complication association with durotomy. They performed epidural pressure measurements, hypothesizing that intradural spread of irrigation fluid caused the observed hypertensive episodes, seizures, neurological deficits, and cauda-equina syndrome, or might even be responsible for milder symptoms such as spinal headaches and neck pain, suggestive of smaller durotomies that went unnoticed. Hydrostatic epidural pressure ranges from 20 to 29 mm Hg with an average of 24.5 mm Hg. They also requested information about irrigation-related adverse events and complications experienced by other endoscopic spine surgeons through a survey application. A total of 766 spine surgeons accessed the online survey. The majority of spine surgeons don't use irrigation pumps during lumbar endoscopy and prefer gravity-assisted irrigation. Only 11% of responding surgeons use an irrigation pump, and 19% operated the pump above 40 mm Hg. It's reasonable to assume that it is based on the hydrostatic epidural pressure range observed in our measurements, ranging from 20 to 29 mm Hg, with an average 24.5 mm Gauss venturi effect. This to calculate the fluid height during the UB, you need to know 1 mm Hg is equal to 1.25 centimeter H2O. The most important thing they found here is that a working cannula should be used for the hole where they use the working tools. Full endoscopic interlaminar surgery was performed on 5 peaks respectively, and their intracranial pressures were recorded. While blood pressure was normal in the first peak, intracranial pressure was recorded. Later, it was measured that while there was high blood pressure, the intracranial pressure was also high. Then a durotomy is performed on the peak, and it is observed that the intercranial pressure increases even more. It was observed that the second or third peak remained normotensive or hypotensive, and intercranial pressure didn't increase throughout the surgery. However, when they performed durotomy, they observed that intracranial pressure increased from then on. The retinal hemorrhage is a Terson syndrome. It is called vitreous bleeding accompanying intracranial hemorrhages, subarachnoid and or subdural. The syndrome is a rare clinical condition that usually presents with decreased vision after subarachnoid hemorrhage. This is a complication I experienced. This is my way of using liquid gravity. After the surgery, the patient lost vision and started bleeding, as in this picture. The patient was almost completely blind the next morning. Of course, a consultant was made to the eye department. It was said that improvement would begin after 6 or 8 weeks. Indeed, the patient began to see again after 8 weeks. You can use such a pump device for liquid use, but the most important thing is to act knowing the structure of the endoscope you use that provides water output. It's very important. For example, see in this video how fast the water comes out when squeezed with a manual pump here. And if the water outlets turned off while using a tool, all the liquid will accumulate inside. You have to be careful. In this picture, the people at the Spine Center are setting up an experimental setup in this mechanism. They perform manipulation while performing surgery with the endoscope and measure the pressure in the cervical, thoracic, and lumbar regions. Studies on this issue continue. And in this video, they are set up an experimental setup on a cadaver at the Spine Center. In this mechanism, they measure the pressure in the cervical, thoracic, lumbar region while performing surgery in the lumbar region with an endoscope. And the studies continue. Due to irrigation with durotomy, that a correlation exists between extradural and intradural pressure, equalization, and its high volume irrigation fluid, or is associated with long surgery times, it is suspected that it may cause problems, especially. Pressure in the lumbar decompression zone is just one consideration in any problem-solving algorithm. Surgical time, canal opening, fluctuations in patients' blood pressure, and interoperative recognition of dural and nerve root injuries are also important in the predicting fluid complications in spinal endoscopy. Control of water flow in the epidural space, your pressure more meaningful than systemic control. And then for water pressure, gravity controlled epidural pressure application with the height at which you hang the saline 24.5 mm Hg, whether patient remains normotensive or hypotensive during the operation. If a durotomy has occurred, being able to complete the surgery as soon as possible, paying close attention to the water pressure and not using a manual pump, not placing an occlusive stopper behind the working cannula, lowering the saline height by 10 or 20 centimeters, using a working cannula during the surgery with UB. Thanks for it.
Thank you, doctor. Any question from floor? Okay.
I don't want to give questions. I want to give comments. I have this kind of complication, but my teacher has a complication after more than 3 hours after surgery. So the patient become blind for temporary. It may be frightened for all our endoscopy. So there is a basic principle for orthopedic using a tourniquet. The problem is when we use water to press the spinal cord to have a fission. The problem is we also block the vascularity to the nerve. So the principal technique of the tourniquet and orthopedy is that every 1.5 hours you have to give to stop the surgery for approximately 10 minutes. So this is the principle. So whether you sometimes when we have surgeries very concentrated and very difficult cases, we don't have a time counter. So we have to remind to the nurse that every 1 or 1.5 hour you have to remind me, especially if we are going to treat or tackle the multiple stenosis, and it may take 5 hours. I have experienced 5 hours of 4-level decompressions. We stop every 1.5 hours for 10 minutes, and there is no problem with it. Thank you so much.
Thank you.
Thank you. Great tips. So we move to next session. I want to introduce Dr. Shiraj Ahmed Mondi from India. His topic is decision making in cervical disc issues, interventions, PECD, PSCD. How do I select my patient? Yes.
Okay. Good afternoon, everyone, and thank Uzbekistan Society to invite me for this conference. So I will straight away go to this lecture about cervical disc and what is our protocol. So now you see, before I start, I just have to give thanks to my all teacher, those who give me the opportunity in my life. So Dr. Gore is my teacher for transfemoral endoscopy, as well as Dr. Anthony Young, and then cervical endoscopy I learned from Dr. Nadkarni, and Dr. Lim and Mr. Hong are my teacher for PSLD. So now you see what happened exactly when a patient comes to you. So exactly the patient want relief. They are at least not interested that what you are going to do with your technique and your options. So they just need a relief, and this relief can, if we can have the option to use minimal or the most least invasive way, we can deal with those people. So here we have to first answer a question to ourselves that do we need a surgery in all of our patient? So suppose if the patient doesn't need surgery, then it's always better that if you can give some lesser invasive options, then the patient will be better, you are also okay, and your result and your outcome will be much better. So now for this we have to go to the basic. So now this is one of my favorite slide. So whenever I have a patient about the disc herniation, so I divide this patient into two, whether the patient is having the inflammatory symptoms or the patient is having the mechanical compression. So if there is a inflammation, it means the patients are a better indication for doing the intervention, and if this is a mechanical pressure, the patient is more good option for decompression. And now you see, now we are able to identify the inflammatory mediators, particularly cytokines, and these cytokines are responsible for intense inflammation, and this is responsible for the very severe pain to the patient. So if you have a patient, if you have the more symptoms and more pain, it means the inflammation is more, and especially you will find it in younger patient. So this inflammation, particularly proteoglycans A2, so contents of proteoglycan A2 is almost 10,000 times more in the disc as compared to the blood. So what happens when this leaks out for the first time, you must have seen the patients are like having very severe excruciating pain, and they are not able to even tolerate the pain. And it's the combination of anti-inflammatory or maybe the steroid or rest, and the time. The most important is the time, which is going to give you the relief to the patient. But if it persists, then we have to do something. So like you see, this is a very difficult time for anyone to make your patient keep calm and avoid the surgery, because most of the patient, if you are able to take control of the pain, then those patients will do very well, and you don't need actual surgery for those patients where they are in actual pain. So now you see, when I have any patient, especially for the cervical disc problem, I divide the patient that whether the patient is having the discogenic pain or the patient is having the radicular symptoms. So if there is a discogenic pain, usually it's mainly because of the small disc annular tear and a small leak, and usually those patients can do very well with conservative treatment. But suppose after your 2 or 3 or 4 week of conservative trial, the patient is not doing well, so we do the intradiscal injection. So like this intradiscal injection, we call it it's a disc lavage. So this disc lavage is actually going to help your patient by just reducing the inflammation. And the most important here is the inflammation is coming within the disc. So when the disc, when you inject inside the disc, so this is actually is going to take the same path of inflammation from inside the disc to, it will go to the annular tear, it will go to the PLL, it will go to the epidural space, it will go to the root. So believe me, this is one of the very, very useful technique for most of the cervical patient, because in cervical area the mechanical compression and the need for the surgery is much less, because you have a very wider canal. So this is how we do the disc lavage. So in which okay, so you can see we always go to the contralateral side. So we go under the fluoroscopic guidance, and then we exactly see. So for the right side we go to the left, and from the left we go to the right. And then you can see, so this is how we do it. So for the right side symptoms, I'm going from the left side. So I use the combination of the local anesthetic with anti-inflammatory medication, and then you can just keep on injecting. So your needle should be at the posterior border, posterior vertebral line, and you can confirm in AP view also, so you know about the target. And then you can inject the contrast to confirm your needle placement. But again, this is one of the most useful techniques. So even for the lumbar patient, if you do the intradiscal injection, it has a much higher value for rather than doing the epidural injection or simple transforaminal injection. So you can see this is the needle placement. So this is my indication for mainly the patient who are having the discogenic pain, and usually you see those patients in the cervical area, they have an interscapular pain, and the pain can go up to the angle of the scapula also. So these are the pain injection. And the most important is you can do the provocation also. So you can even confirm that this patient's pain is coming from here, and the pain is actual coming from this disc. So this is going to give you the exact diagnosis also, that what you are working. So like to me and to my patient, this is more of a diagnostic value, but I tell you that usually 80 to 90% of the patient with simple disc herniation, they will just do very well, and the young patients especially, because it just work on exactly on the site, and you are able to deposit the drug exactly on the area of the inflammation. And the third thing is, with this, when you inject little volume, this is going to wash out all the chemical mediators of inflammation. So because of that, your patient are going to get immediate relief, and the results are excellent. So now there are some other group of patients who are having the radicular symptoms are more. They don't have a discogenic pain. So in those patients we do the procedure called the neuroplasty. So in neuroplasty we can just you can see that again we go from the contralateral side to the interlaminar area, then we pass a small catheter, and we actually try to go to the lateral epidural space, and then you inject the contrast. So here exactly you have to see that the contrast should be coming out of the foramen. So this is, we call this a kind of a safety leak, which is going to help you. Otherwise if you inject a little more volume, then this is going to give the more epidural pressure. So we don't need that. And now if you have the big herniation and you see that this is more of a mechanical compression, then I like to do the anterior cervical discectomy. So the indication for the anterior cervical discectomy for me is a central disc and especially soft straight disc. So we can easily target with the anterior approach, and the best thing is we are doing all of this under local anesthesia. So when we are doing under local anesthesia, so our awake patients are the best neurological monitor, and because of when the patient is awake, you can monitor patient directly and you can avoid all possible preventable complication because patients are going to tell you. So this is how we do it. You can see there are many advantages of PECD, and especially here we are just targeting the extruded part of the disc which is herniated out. The rest of the disc we don't touch much. So you see, this is how we give the position to the patient, because if you have the C5, C6 or below level, then the shoulder will come in between, so you are not able to visualize the things nicely. So this bandage is required, but if you explain the patient nicely, they usually cooperate. And then you can see this is the MRI, and this is the pre-op MRI. And now you see the most important aspect is the needle entry. So the needle entry is very crucial, that you have to go. So like normally you have to take care not only about the trachea and the carotid, but the most important is esophagus. So your fingers should be touching directly. There should be no structure between your skin and patient's skin and the anterior part of the vertebral body. And then you just dock from the skin inside the disc in the lateral view, and then you can start working. And then you can see you can do the discectomy also. I don't know, my videos are not working, but it's okay. We have short time also. And this is like the depth of the instrument, so you can go at least up to the half of the facet safely, and exactly you are visualizing everything. So when you have everything under visualization, there is no problem. And you can see these are some small pieces of the disc we are removing. And this is the endpoint. So you can see through the PLL, the pulsatile dura, and you can clearly observe that now the extruded part you have already removed. So now you will get a very less number of patients like this, those who are having the soft cervical disc which is protruding and giving the mechanical compression, and they are not being relieved with any other option. But when you have this option available, so you can select those patients also. And you can see this is an immediate post-op. You can see this is a very small cut, the patient. And this is the post-op MRI. So this is confirming that the disc which was bulging, we already removed it. And these are some other patients which you can see the pre-op and post-op MRI. So now for with the advent of more interlaminar options, this anterior cervical discectomy now we are doing less, but still like it has some good indication. And especially we have the new instrument in terms of bendable instrument and in terms of the angle instrument. So they are helping us to improve your outcome. Especially Dr. Gore's hook is also very, very useful. And we have the small 2 mm bendable curette, because this scope is having only 2.1 to 2.7 mm working channel. So you should have very small instrument for that. And then we use the anti-inflammatory PRP medicine called the DARE1 plug. So this is also very useful, that it acts as a powerful anti-inflammatory, and actually you can use it to reduce the inflammation as well as the regeneration of the disc. And this is also one of the very good way to reduce the post-operative inflammation if you are able to inject it inside the cannula. And then now you have the patient who are having the pathology posteriorly, so you can do the PSCD. I will not go into the detail, I will just skip those slides. So we use the 8.4 mm endoscope, and this is how we do it. So like the best thing is like I do all of my cervical as well as the lumbar cases under local anesthesia, unless until if it is a contraindication from the patient. So like more than 98% of my surgeries are always under local anesthesia. I do all even stenosis, lumbar, cervical, even bilateral decompression under local anesthesia. I have so many friends here who have seen us working in our center. So the best thing is like, see, the previous 2 lectures was giving the idea about the fluid management. So and any other complication. So when you have your patient awake, and even sometime up to the extent that people say me, why you are so obsessed with the local anesthesia in endoscopy when you can do it comfortably under general anesthesia. So my worry is mainly about the fluid pressure. But this is something like even the majority of the doctors, they don't understand. They say my anesthetist is not good because he gives so much of the sedation, so my patient doesn't wake up after the surgery, and then we have to give the overnight intubation, or we have to shift to the ICU. So that issue is mainly because of the fluid, because the fluid is having the tremendous advantage in endoscopic surgery, but at the same time the fluid pressure management. So this fluid can give you 2 issues. One is the dilutional hyponatremia by absorbing the fluid through the venous channels inside the blood volume, and the second thing is the compression effect when the fluid goes through the dura, and it actually increases the dural pressure. So invariably every patient after having 1 hour or 2 hours, depending upon the surgery, they always have a neck pain, and the general anesthesia doesn't prevent it, it just masks the patient's symptoms. So this is very, very important. And doing the stenosis surgery or the cervical surgery under local anesthesia is quite possible. We have been doing since last 4 to 5 years, and we are quite successful. We have even trained so many doctors also about this, and now they have also started using the under local anesthesia, because this is something going to give you so much relief, because you are not worried about any neurology or a neurological complication. So I will not go into the detail about how we do this, and see, we always put a small drain, so that is helpful. But you see here also our patient is awake, so I can always talk to those patients when we are doing the surgery, and it's easily doable. Recently, just before 10 days, we had a conference, and we show it to all of our delegates live in the theater. And I don't want to go for the follow-up or something, so this is just okay. And even foraminal or the paracentral herniation, you can easily do it with the posterior cervical endoscopy. Even you can do the posterior cervical foraminotomy. So my take-home message is that we have to be conservative as much as possible. The local anesthesia, whenever it's applicable, it has a tremendous advantage because you are avoiding general anesthesia and all the complications related to general anesthesia. And since we are the part of industry, so we use so many new instruments. So these instruments are helping us to overcome the difficulties, and now we are going with the new indications. The anti-inflammatory PRP Dervan plug is very useful because it just helps you to reduce the post-operative inflammation. So even since it's a platelet, so even it stops the bleeding also, and since it's having the spinning growth factor, so it helps to regenerate the tissue also, and it's very cheap. And now since for the anti-cervical scope, since the optics is very small, so you don't have a better vision. But now the development is coming in terms of a chip-on-tip system, where you will have a chip on the tip of the scope, and then it can just transmit the picture directly to the camera system. So this chip-on-tip system is going to be very useful for a smaller scope. So like in the future, there are a very high chance that with the improvement of the optics, this chip-on-tip will make the size of the scope much smaller and smaller. Thank you.
Thank you, doctor. Any question from floor? So because of time, we should move to next speaker. Thank you, doctor.
Thank you.
So let me introduce the next speaker, Dr. Urapot Wikchan from Thailand. His topic is a hybrid endoscopic intradural and extramedullary T9 tumor removal. if possible, like doctors in outside having lunch, it's better to come back to join our last schedule. So if you can ask them to come back, please.
Good afternoon, everybody. My name is Dr. Vorapot Vichan. I am an orthopedist from Thailand. And today, I would like to thank Dr. Lim Kangtek and the Uzmiss 2024 committee for an opportunity for me. I have no conflict of interest. My topic today, I think it's different from the other speaker because I think this mix and match technique and education for surgery that's different from other surgeon. And why is hybrid and what is hybrid and why hybrid and how to do it? Of course, that hybrid style will have, some of the advantages more than uniportal and biportal, something like that. When I was a beginner for endoscopic spine surgery, I wonder there's a lot of things such as how can endoscopic do, because it's also many companies and design of the endoscopic lens and instruments like this. In real life, we have many techniques to do because patients have different problems and also have different area or levels. Therefore, you should do maybe everything, like a technique, uniportal, biportal, and also in different area. Okay, sorry. That's my life. Pincetter view. Okay, because different problem can also resolve from a different technique. We look for this herniation and the technique for this discectomy, transfemoral interlaminar or something like a UBE, and we have stenosis problem from patients, and we have different area like a lumbar spine, thoracic spine, and C-spine, and also now that a big trend is lumbar interbody fusion from endoscopic technique. Of course, that's about our budget because everything is very, very expensive, and you have to learn from different many of experts. In my real life, in my daily practice, sometimes I do uniportal, sometimes I do biportal, and sometimes I do hybrid technique. And now, of course, we do endoscopic T-lift. This is up to patient's conditions and our experience. And how hybrid spine works? You know, hybrid spine acts like you use the lens from uniportal, and you act like a biportal, and you can also use two portal to work simultaneously, like this. You see on the video. This another portal. This I act like a UBE style. On the left video, now I use a uniportal working channel. And how about endoscopic thoracic surgery? Of course, like a lumbar area, we have this problem, stenosis, and also tumor or infection. We have different approaches. It is up to the lesion and pathology, from interlaminar, from the transforaminal, and maybe WAS, video assist, thoracic surgery. And how about endoscopic thoracic tumor removal? Of course, in the past, we do open. We have micro endoscopic assisted and UBE, like a Descendue technique, and full endoscopic and hybrid. That can be my present today. There's many of surgeons had reported like endoscopic assisted to remove tumor in thoracic spine. And how about the full endoscopic? Of course, that many of doctors reported, like Dr. Vincent Hagel from Germany. He used big lens, interlaminar lens, to remove by full endoscopic technique, and he can repair the dura at L12 intradural tumor. And my technique, foraminal lens, because I just have one, and biportal style that take advantages for irrigation system and two working portal and optimize the RF to work. In this case, female, 69 years old, intradural extramedullary tumor of T10. Of course, preoperative planning is crucial. You must know how much bone that you have to resect, like laminotomy, and how wide to remove. Then, after general anesthesia, you set up in the prone F position on the radiolucent table, and routine saline, C-arm checkup, and start identify level. I recommend identify level on the AP view from the fluoroscopic, fluoroscopic, because this is an easy way to identify. But you have to count the leaf from the T12, and you will find the lesion. You will find the level that you need, and check the direction on the lateral view. After scope, I clear the lower lamina of the T10 and upper lamina of the T9. Clear, identify level, and make sure that you have the correct position, correct levels. And then start during laminotomy of T10. I approach on the right side, left side, because the tumor dominates on the left side. Laminotomy enough to reach the tumor safely. And then I make another portal, like a UBE style, to do durotomy. And then I extend durotomy. You see some part of a tumor that's come out. This technique, I took it to uniportal style and start remove tumor. Before this, I make sure, because before I remove tumor, I make sure that I was in the right position, in the right level, and saw some of a tumor part, something like this, and start to remove it. It's quite big because of my endoscope is 6.3 millimeters. It's bigger than the working channel. That size of working channel is 3.7 millimeters. And how to repair dura after durotomy? The most difficult part is to repair dura. At that time, in my thought, I think that I would have to secure the stitch and how to make the stitch. This decision I took it to biportal style. I use a zigzag technique to repair dura and use multi-filament of suture because I think that's a secure, easier secure more than the monofilament. Like this. I tie the end of the suture and cut it. You can see it's secure. There's a tumor. The patho is meningioarterial meningioma. It's quite big and multiple pieces. There's a pre-op and post-op MRI after 3 months. Take-home message, hybrid endoscopic technique. You would have irrigation system instantly, more working portal, and appropriate TRF for different areas to work. And endoscopic tumor removal, there's alternative choice. Endoscopic technique is the future, becoming the gold standard and can replace conventional procedure. You have many weapons. Even more, you have pencil. And finally, you will have the weapon you like. Next year, I would like to invite you all to our meeting, Uzmiss, the 10th Uzmiss. We have the best cadaver program, scientific program, and we have the culture and natural. Like this year, we organized the 15th Thai Miss 2024. And finally, we found the IECSS International Endoscopic Cervical Surgery Society with Professor Lim Kang Tek. Thank you.
Thank you for a good presentation. Any question from floor? Okay. Okay, thank you, doctor. And from the live surgery, thank you for a good presentation. From the live surgery, Dr. Lim want to show the endpoint of surgery. Can you connect the theater?
The L3 for bilateral compression also. Yeah. dissector. Yeah. It's you can see it's ipsilateral, lateral margin, and the dura. No, it's annulus, right? Annulus, and then contralateral side also. It's annulus and lateral margin, right? Finish. And how was the L45? They saw the contralateral side of it?
No, no, they didn't see it.
Okay. It's L34. I performed L45 obturator with a jumping technique.
No.
It's two.
No.
Obturate. I checked the 45. Sham. It's okay.
Johan,
I'll show you L45. Sham.
Стол куташки.
It's I checked. So,
okay.
Okay, it's L45.
Bold.
Okay, proceed. It's hematoma inside. Okay. 45. Ipsilateral here. Can you see the contralateral side foraminotomy? See on view?
Надо показать. Вот это. Там не видно. Да, лучше сейчас.
Proceed. Dissector. There is a hematoma inside. It's a foramen. You can see. That is. What's it? Retractor. It's not easy. It's the L. It's red one is L4 root. L4. Sorry. Anyway, it's L4 root, red one, and the foramen, foraminal decompression, and it's L5 root here, and the ipsilateral also, bipolar, and the forceps. Okay, dissector. It's ipsilateral L5 root, annulus, okay? It's a pedicle area. Finish. And then it's a contralateral side, and then foramen. Inside the red one is L4 root. L4. It's outside. Okay, you can see the CM AP view. There. It's a foraminal TB. Okay, I'll finish 4. 3.
The endoscopic view is not very clear, but we can imagine what you're trying to show us.
Well, just
and
one?
Yeah. But thank you very much, Dr. Lim. We will give you a massage.
One more important?
No.
One is enough?
It's your mistake. Your responsibility. You didn't prepare the.
It's this brain which you are using. It's not relevant.
Sham again.
What's so the operation is finished. So
Uzib tashlayin bo'ldi. O'chiring. Drelni o'chiring bo'ldi, kerak emas. Bo'ldi, tugadi.
Sham.
So it looks like operation finishes. So let's come back to our presentation.
Sham.
Okay, so we came back. So I want to introduce next speaker. He's already in the stage. Dr. Adam Moeljoro from Indonesia. His topic is endoscopic anterior cervical corpectomy and fusion in C45 cervical tuberculosis. Please.
Okay. Assalamualaikum. Good evening. Thank you so much for the invitation to Dr. Somansur Saturno, Dr. Akhlor Yakubov, and all organizing staff that already having this meeting so very well organized. I'm going to present the endoscopic anterior cervical corpectomy and fusion, endoscopic CCF, in C45 cervical tuberculosis pod disease. I'm an orthopedic spine surgeon, work in Gajah Mada Academic Hospital. It is a teaching hospital in Yogyakarta, not Jakarta. Yogyakarta is 600 kilometers east from Jakarta, the capital of Indonesia. And I'm not a single variant of endoscopic surgeon. I try to learn all the technique, PSLD, transforaminal, and also UBE. And in Indonesia you can see the map is small here. If you know Bali, this is my one of favorite islands. If you visit Bali, it is only 1 hour flight from my cities. You should try it before you die. You have to travel to that island first. As we know that tuberculosis of the spine is a small number, but it is common in our country because it is 0.916 per 100,000 males, and female is larger. And the cervical spondylitis is 2 to 5% of all cases. And it is common also in the other developing countries such as India, Bangladesh, Afghanistan, Pakistan, Africa, and Indonesia. The manifest is the sign and symptoms such as neck pain, stiffness, fever, night sweat, weight loss, extremity weakness, and numbness. Usually we perform open anterior cervical corpectomy and fusion. As we know, the incision is approximately 5 to 6 centimeters, and we will put the cusp bar, and everyone know how to perform this SCDF or SCCF. But there is a potential injury for the endoscopic if we want to try. It's different when a lumbar or thoracic, when you can directly put the scope and directly land in the bone. But the endoscopic SCDF, whenever you want to try to dock, it will already become a problem. The first is the recurrent laryngeal nerve, and the second is the esophagus, okay, and also the vascular structures, the carotid sheath, and the longus muscle distractions. And the question is it possible to do endoscopic SCCF? As we say that this picture is vintage from Dr. Kang Tae Lim. He inspired me to do the SCCF, but before this, I have to perform endoscopic SCDF first as a training. Reporting case of 45-year-old woman present with progressing tetraparesis over a course of a month, causes by vertebral C4-5 pathologic fractures caused by TB spondylitis. Is consulted from the neurology department to our department, and they said that conservative treatment was ineffective. As you can see, there is from sagittal view, you can see the highly pressures from the distracted bone to the spinal cord, and you can see also that the from axial view, the compression is very bad. So you can see the spinal cord is compressed more than 50%. And we checked for a preoperative ASIA score and the motoric is 2/5 in all extremities, and the patient bedridden. Whenever we want to try this technique, it is because the patient is very thin, so any open surgery will cause a problem for the wound healing of the patients. So we decided to do endoscopic SCCF. As spine surgeon, I'm trying to do open SCCF directly for this patient, but because we learn so much, and every month or every 2 months we go for the meeting, we are trying to do endoscopic, and we inform to the patient whenever we have a failure, we can convert to the open directly. We can do also open laminectomy or fusion or open door laminoplasty, but where is the idea coming from? There is a publication from the Dr. Kang Tae Lim, full endoscopic anterior cervical discectomy and interbody fusion in patient for cervical spondylitic myelopathy. And also there is a publication from China that they already performed this kind of SCDF endoscopic, under endoscopic. And how to achieve that kind of a learning curve, I usually watch the YouTube more than maybe 10 to 20 times, and I imagine that I'm doing the surgery. So every morning I try to practice it. So whenever you watch the YouTube or the video over and over again and imagining the shadow surgery, it is like you do the next level surgery, the increasing your experience. And the skin incision is, we have to check, the normal incision is like this for open, and we try to use this 1 centimeter incision. And for surgery set, we used Max Moore, and we used the Richard Wolf, and also the drill, we used the NSK Primado 2, and the instrument, we used the Hankill instrument. So the strategy is same like the open surgery, SCCF surgery. We have to land and without injuring the nerve or the structures in front of the cervical. And the patient preparation is like this, as you can see the previous presentation that presented by Dr. Shiraz Munsi. We can press the neck like this and push to the lateral, and we can directly put the needle for the endoscopic SCDF. How to prevent the esophagus damage? We have to put the NGT and to make the esophagus in a rigid position, so we will not directly penetrate through the esophagus. And the vascular sheath, we use our finger breath to palpate the pulsation of the vascular, the artery and carotid. And endoscope related, I ask assistant to hold the scope whenever I have missed or sliding, because in the cervical, the soft tissue is so thin, so I can possibly or inadvertently slide and miss the level. And the backup surgeons in a teaching hospital, we ask for the vascular surgeon to stand by whenever I injured the vascular, or whenever I may injure the esophagus, I'll ask my friend to back up for me. As you can see, this is the entry, the cage preparation, and also the final view. As you can see here, the picture is not very clear because there is bleeding also, and you can see there are bony dissemination C4-5. This is ipsilateral contralateral, and you can see we perform corpectomy slowly with the Carrison 2 mm, and you can see the lateral side of the C-arm is like this. We try to put our Carrison slowly so we do not injure the spinal cord due to our Carrison and our cauters. And for water pressure, I use gravity, so the pressure is not so high. But if there is a bleeding, we are also prepare for the pump. And you can see there's after we take out all the bone, we try to clear the soft tissue around it. Sometimes it come in and come out, come in and come out. And we also clear the disseminated partial C4-5 bone, and we perform also discectomy, both of the disc C3-4 and disc C4-5. So this is a double SCDF, discectomy and also corpectomy. So we have to make sure the C3 inferior and C6 superior end plate is clear, to make sure the fusion bed is very good. And this is the final view of the corpectomy. In this position, we tilt the scope like Dr. Lim you saw in the live surgery, rotated at the left side like this, because this is a 10 or 12 degree or 15 degree to the superior. You can see from the right side by tilting to the left. And if you want to see the cranial, you just tilt like this to the right side, so you can see, and the spinal cord is clearly, and no compression and no bony compression over there. And I try to burn the bleeding, so that will prevent the hematoma and cause the pressure of the spinal cord. As you can see, the cervical spinal cord is clear. And this is the C-arm pre-corpectomy, and this is the C-arm post-corpectomy. As you can see, the whole bone is diminished, but there is still side bone. We try to keep the healthy bone there, so that the cage will be very safe. The problem if putting endoscopic SCCF is just like endoscopic SCCF. You cannot see the plate, so we have to fix with the screws. We don't have the standalone cage screws. It is only available for SCDF, but not for SCCF. To facilitate, we put the slight incision just to put the cage. You can see the cage, the titanium cage right here, and we use the allograft and also the cage, and we measure it when we put it, And for the screw, for the locking, we used the screw, and we lock the superior and inferior and to block the movement to anterior. And this is the final C-arm, AP and lateral. I know that this condition is not very ideal, not straight, but we still try to keep the other side is still have a slight bone. So we do not try to take it out the bone to make the cage straight. As long as it is fixed and stable, we keep it there like that. And this is the lateral view. And then this is X-ray. And we cannot perform the MRI post-op because our machine cannot detect the instrument or the implant whenever it is put less than 3 months. So we just check for the clinical and post-operative score, clinical score. Post-operative 1 month, this is the incision, and this walkability recovers. The patient can walk. We usually give the patient WhatsApp number so they can give us follow-up clinical pictures if there is worsening or something. This is taken by in her house by her child. So, and whenever he visit us, visit us, I check the range of motion of the neck, and the patient is very happy because she recovered. There is a saying quote from the Usain Bolt that he tried to run 9 seconds. Try doing that and practicing for 4 years, and people is stopping when they don't see result for 2 months. So I encourage all young spine surgeons who want to pursue the career in endoscopic. You have to dedicate yourself, and remember that Usain Bolt also has scoliosis, 40 degrees scoliosis, but he refused to have a surgery. But he trained all the time. That's not obstacle to make the world record. So this condition will have you may have a difficult operation time at the first 50 patient, but don't worry, the time will reduce after time. So if you see you see the speakers here, you know that it is like an easy surgery, but no, actually we have many persistence, failure, sacrifice, disappointment, complication, and hard work. So I try to motivate you to start endoscopic. And this is the saying also from Mukesh Ambani, that you have to align your patient and purpose in life with goals. Because if you please focus on goal, because if you focus on goal, you will overcome all obstacles. But if you focus on obstacle, you cannot achieve your goals. So here after the seminar, or you have to try little by little. And thank you for my teacher. If I have seen further than others, it is by standing upon the shoulder of giants. Thank you so much for inviting me.
Thank you, Dr. Adams. Any question from floor? Okay. Can you find the mic to him? Anyone, could you find a mic?
We are going to have a endoscopic meeting August. You can visit, or you can join us.
Thank you very much. Your very impressive lecture. Okay. So I always curious about anterior approach, endoscopic anterior approach. If we are doing endoscopic surgery, how can you prevent normal cell line spread out the soft tissue, the anterior part? Sometimes normal cell line spread out in the anterior part.
Yes, this is good questions. To prevent the normal cell line, we have to know the MAP of the patients. the blood pressure, and we try to give a gravity. And first of all, we can see that every time I use, because this is a uniportal, the flow of the fluid and the suction of the fluid is in one tube. So I try the pressure of the water with my finger. So whenever I ask the nurse to take off the gravity of the water, since if the pressure of the finger is so like too fast, tap like this, I try to reduce it, and then it is like a touching like this. When you try to operate the ACDF or cervical posterior, we usually touch the nerve like the posterior foraminotomy. We touch with the hook very slowly with the feeling like this. I feel the water put my hand very light like this. So that's why you cannot see the vision is very clear. It is slightly blurry because if I want high pressure, I may see it clear, but it's the pressure is very high. So that's how I try to. There is still blood coming from all over. So it is. I make sure that the pressure is not so high. And the second, whenever I try to give to perform this, I checked also the central. We put the central venous pressure to check if there is the pressure to the brain or the blood pressure is not going down. Because if there is a pressure is too much to the dura or the spinal cord, the pressure, the anesthesiologist will notice that the pressure will go down because of the pressure of the water. Thank you so much for the questions.
Thank you. Okay, other question? Could you send the mic to him?
And how long will you continue anti-TB drug? How long will you continue anti-TB drug?
Anti-tuberculosis
medication. In anti-tuberculosis drug, there is a consensus made for extrapulmonary tuberculosis. In my country, there is a protocol more than 9 months, but it is managed by the other department since the government. This is the government policy that the anti-TB drugs is given by the pulmonary or intern department. Actually, we usually give to 9 to 12 months, and we check the liver function test and also the check for the every liver function test, kidney function test, and we check also everything, the LED, the everything. They take care of that.
Any more questions? Thank you, doctor. Okay, so let's move to the next presentation.
Thank you very much.
Thank you. And next speaker is Dr. Kelmakov Vladislav from Russia. And his topic is posterior endoscopic decompression for the treatment of thoracic myelopathy caused by spinal stenosis. Okay.
Здравствуйте, приветствую вас на втором дне конференции. Благодарю организаторов за то, что дали мне возможность приехать, поучаствовать в этой конференции. Сейчас я вам презентация. Я хочу показать грудную миелопатию, которая вызвана достаточно редким заболеванием. Это сейчас я расскажу. В начале история эндоскопической операции на грудном отделе. Изначально развивали торакоскопию для того, чтобы обследовать органы грудной клетки. легкие, плевру и так далее. Использовали цистоскоп, троакар. Это первый человек, который эндоскопически внедрился в грудную клетку. И в дальнейшем начали развиваться торакоскопические эндоскопы и хирургия. Но затем доктор Джо написал случай, когда он удалил грыжу диска из дожального доступа на грудном отделе позвоночника. И с этого момента началась развиваться эндоскопия, как нам привычная сейчас, торакального отдела позвоночника. Ну, цель операции – это уменьшение травмы, уменьшение боли и с соответствующим качеством лечения. Вот это заболевание, которое вызывает грудную миелопатию, это окостенение желтой связки. Оно очень редкое. В этих публикациях написано, что люди в Китае страдают около 3-4%, в Японии страдают 6%, и это люди без симптомов этого заболевания, то есть они не имеют миелопатии изначально, но в дальнейшем осификация увеличивается и появляется миелопатия. Чтобы понимать редкость этого заболевания, оно распространено меньше, чем при ОПЛЛ и выше при грыжах диска грудного отдела позвоночника. Особенность этого заболевания, когда у человека появляется симптоматика, невозможно вылечить этого человека консервативно. После возникновения симптоматики надо проводить обязательно операцию. Консервативное лечение не помогает. В настоящее время широко используют всякие разные методы, типа ламинопластики, стандартные грудные подходы к позвоночнику грудного отдела, но это недостаточно хорошо, потому что массивная травма, кровопотеря, это не очень положительно сказывается на выздоровлении пациента. Также некоторые авторы после ляминэктомии обязательно делают фиксацию, потому что для них кажется это правильным решением после таких декомпрессий. Это заболевание не осталось незамеченным, его изучают в основном в Азии, и этот автор Сата даже ввел классификацию этого стеноза. Он разделил их на 5 уровней в зависимости от развития этой осификации. У нас было несколько случаев. Один из случаев стеноза на уровне 9-10 грудных позвонков, пациент с миелопатией. И, естественно, консервативное лечение ему не поможет. Мы предложили операцию из заднего доступа, высверлили дугу, высверлили осифицированную желтую связку и декомпримировали спинной мозг. Такие операции, после таких операций пациент восстанавливается достаточно быстро, маленькая рана, и уходит миелопатия постоянно. Это КТ после операции, видно окно. В этом это мета-анализ. Здесь включены 23 статьи. В этот метод-анализ включены осложнения при торакальной эндоскопии, и по осложнениям очень мало написано. Люди почему-то не хотят говорить про свои ошибки и включают 323 пациента, из них только 35 было с осложнениями, с повреждением дурального мешка, с ухудшением неврологической симптоматики. Этот пациент до операции был нами прооперирован с выраженным стенозом. У нас еще нет контроля, и после операции уже имеется регресс симптоматики миелопатии. Когда приедем, сделаем уже контроль. Спасибо вам за внимание.
So any question from floor? Okay, thank you so much for presentation.
Спасибо.
And we'll move to next presentation. Dr. Bhupesh Patel from India. His presentation is the cervical endoscopic laminophoraminotomy for calcified disc.
Good evening, everyone again. So today, how to remove the calcified disc in posterior cervical endoscopic laminophoraminotomy. I'm Dr. Bhupesh Patel. So now as we know, recently the endoscopic surgery for cervical disc disease also has gained traction due to preservation of very important posterior neck muscle, because cervical neck balance is very important. So each and every movement of cervical spine associated with intrinsic tone of the posterior neck muscle. So whenever we cut the posterior neck muscle, there is a loss of this intrinsic tone and proprioception of the neck muscle. So again, most of the patient with open laminectomy and laminophoraminotomy have some kind of neck pain. Again, second thing, important thing is avoidance of the fusion and subsequent adjacent segment degeneration. And second thing, third most important part why we do endoscopy is better dealing of foraminal pathology. Because in endoscopy, and what is the difference between endoscopy and a microscope? Microscope, we are approaching the same thing from distance. In endoscope, as we feel, we are doing surgery at the very near to the pathology. But again, removal of calcified disc via posterior approach remain challenging task. Because why? It needs excessive mobilization of nerve root. Sometime root tear, or we just remove some, there was a tear of a root sleeve. And again, the instrument what we are using are very delicate instruments. So sometime we may break, or it's very difficult to remove the calcified hard disc. Instrument breakage is more, and if you go little more lateral in order to remove the calcified disc, lateral is dangerous vertebral artery. And most of the time, it is not every time it's necessary to remove the calcified disc. Most of the time, if you de-roof the foramen, if your root mobility is good, then you can avoid removing calcified disc. But many times it's like calcified hump. When there's calcified hump, you cannot go too lateral, because you just remove the lateral mass, and excessive removal of lateral mass create instability and postoperative neck pain. And sometimes if you go more laterally, then vertebral artery comes in the way. So in cervical spine, everything is very near to each other. So it's dangerous to go more laterally. So if the calcified disc is humping and root is bumping over the calcified disc, then we may need to remove this disc. And how I do it? I use a small size monoportal scope around 4.3 millimeter working channel and 6.9 millimeter outer diameter, because you don't need to remove, you don't need to use the cautery or radio frequency probe and too much muscles ablation. So smaller scope directly land on the V junction and just start drilling. So there is minimal handling of the bony anatomy. Again, use a very small instrument because cervical spine need very small delicate instrument. And for removal of cervical calcified disc, I use the specially designed chisel which is available with Hepson. It is a semi-tubular with T-handle, semi-tubular edge with T-handle. Edges are very smooth. So if you used against the nerve root, we cannot, nerve root are not going to damage and we cannot pinch the nerve root. Again, when you use the chisel, just to remove the calcified, use gentle hammering. And its size is, of chisel is 3.5 millimeter. So this is the one case, 70-year-old male with severe left arm pain since 2 years, not able to sleep because of severe pain, and there is no upper motor neuron sign, but he definitely have weakness in left upper limb and left lower limb. So you can see at the C5, C6, there is soft disc herniation, and 5, 6, there is a hypertrophied lateral mass and some calcified disc herniation. Any marker is not there. So you can see the C5, C6. So what I did, C7. Hello, sir. So this is a C5, C6. So there is auxiliary osteophyte. I'm somehow not able to play. No, this video is not playing. So you see with not okay, it's playing there. So you see with the osteotome against the nerve root, we are gently hammering and we remove that calcified disc. So again with osteotome only, you just retract the disc and just try to remove the disc from the axilla. And this is the final decompression. Nicely visible. And this is a C67 level. It was soft disc, so we don't need to do any hammering. And with a single incision, you can do both level nicely. Again, one more. Here you can see at a C5, C6. Very tight stenosis and calcification because there is a long extent since 1.5 months, 1.5 year, patient having the pain, but increase since 2 months, and it's very severe with grip weakness. You can see the very foraminal disc with calcification. So again, same small scope with calcification we remove. Again, beware of bleeding because when you are doing all calcified work, there is a lot of bleeding more than what you do in the normal soft disc herniation. So with this sleeve, you can just gently retract the nerve root and put against the nerve root. So your semitubular curve part, concave part should be facing outward and convex part should face to the nerve root. So to conclude, calcified disc is common in long-standing cervical disc herniation. It is safe to remove calcified disc with proper planning, with proper instrument. Bleeding is more compared to soft disc, and you should be very careful to root injury during the disc removal. Thank you.
Thank you, doctors. Any question from floor? Okay.
Thank you very much for your great presentation. So how can you remove just the ventrally located and just the medially located, just under the root?
Yeah.
Ventral, what I mean?
No,
how can you remove?
paracentral and foraminal we can
yeah.
remove. Central disc we
Central,
cannot remove.
just central calcified disc.
Central we cannot do.
Okay.
Even central soft disc, I think, is a
soft disc no
contraindication for posterior cervical surgery.
Calcified disc you can.
Paracentral and foraminal we can do.
Okay.
But many times what happens, we assume that we have completely decompressed the foramen, but disc is very large calcified. So sometimes even removing foramen, disc is not going to free. So many times we have to remove calcified portion in order to complete mobilization of nerve root.
Okay, thank you very much.
Thank you.
Any more question? Okay, thank you so much. Yes. The topics on the program I already presented yesterday, so today I prepared another presentation. The topic is transforaminal lumbar foraminotomy for lumbar foraminal stenosis. Transforaminal endoscopic lumbar foraminotomy is well-known procedure. But actually that was started from a part of transforaminal discectomy to make a pathway to the disc at the foramen. And the usefulness and advantages of foraminotomy alone is not emphasized and just stay behind the mainstream of the technical development. And the first report was in 2003. Usefulness of transforaminal foraminotomy alone. And after 11 years, in the same doctor, An Young from Urido Hospital, he reported safer and detailed techniques for the foraminotomy alone. And there is two technical issues in successful decompression. First is the identification of exiting root passage before extraforaminal ligament decompression. And second is bone and ligament unlooping until the ligament flavum is exposed. Actually, the bone decompression is easier and ligament decompression is more difficult. And in 2021, there's a meta-analysis for transforaminal foraminotomy. In their conclusion, the procedure is very useful and safe, but indicated in elderly and patients with comorbidity. So in this meta-analysis, the indication is still very narrow. Before to go to the topic, I want to talk about the ligament outside the foramen, because actually we do not know well about some structures just outside the foramen, especially the ligament. And also the studies about anatomy study, only there are a few studies exist. And there's some layer of ligament. From outside to inside, the first layer of ligament is intertransverse ligament. It is rarely seen in transforaminal approach. When we do the transforaminal approach, first ligament we can see that is a corporal transverse ligament. And next level is extraforaminal ligament. And within the foramen, that is transforaminal ligament. And in this picture, the yellow one is corporal transverse ligament, superior and inferior. And blue one is extraforaminal ligament. from another research. The yellow one is a superior and inferior corporal-transverse ligament. Look at this in the left side. The ligament is attached to the lateral border of superior articular process. So when we do the transforaminal approach, we can see this ligament. But this is not a big ligament. It exists as some small fascicle or small bundle of ligament. So easily can be ignored, or during the approach can be cut without any identification. But after this ligament, transforaminal pad is located. And in the right side, that is another newer report. The corporal transverse ligament looks thicker than previously the research. And the extraforaminal ligament, that is thicker than corporal transverse ligament. And there's two extraforaminal ligaments, superior and inferior. And okay, it's not coming. So when we do the transforaminal approach, usually we can see the inferior transforaminal ligament, but not posterior. But because superior extraforaminal ligament is located above the root and in the site of the isthmus. Okay, this picture is more confused. So let's go to the next picture. This is a report from 2020. This is a newer study. It shows more relevant shape of extraforaminal ligament, and they are bigger than previous studies. In the picture, there's two ligaments in superior extraforaminal ligament and inferior extraforaminal ligament. And this ligament, especially inferior extraforaminal ligament, that is attached to the root. So it is not easy to remove whole of inferior extraforaminal ligament. Superior extraforaminal ligament, much easier. Let's go a case. This is a very old lady, has a left side leg pain. And this MRI before and MRI and CT before operation, there's some central stenosis. And when we go to left side, we can see the foraminal stenosis because of the superior articular process elongation and severe foraminal stenosis. Like in these cases, mostly we choose the fusion, T-lip or O-lip for patient, but we are endoscopists, so always we should find except of fusion operation. So in this case, the foraminotomy alone is a good case for the surgery. Look at this, very thick and hypertrophic superior articular process. And this video. Okay, this is in the left side, that is cranial, and right side is caudal. After removing some corporal transverse ligament, and we could see thick SAP, and after drilling, we can see inside of the superior articular process, and more drilling and cutting to make it thin. So in the 9 o'clock, there is a cranial. So after thinning of the SAP, I made a crack to remove the SAP envelope. Yes, there's a big block of SAP. We could remove it. So most of bone decompression is achieved by the embryonic decompression, but will be not enough. So more drilling to get more decompression. And about 11 o'clock and 10 o'clock, you can see superior extraforaminal ligament. Yes, that is a superior extraforaminal ligament. That is located above the root And in 9 to 10 o'clock, that is upper pedicle. So we can see the exiting root, and in the 5 o'clock side, that is disc. I'm doing more decompression to make more space at the foramen. We can see the root. That is shoulder of root. So this is total decompression of foramen. Shoulder and axilla you can see. And after removing the superior extraforaminal ligament, you can see the yellow ligament in yellow color. That is endpoint of foraminal decompression. So in left side, that is before operation, and right side, that is after operation. You can see decompressed foramen. So by the transforaminal foramenotomy alone, we can do the decompression of foramen effectively without the fusion operation. In conclusion, transforaminal lumbar foramenotomy is a good and worthy method for lumbar foraminal decompression, especially for superior articular process elongation, and superimposed facet joint is a good indication. But we got technical difficulties. First is confusing bone and ligament anatomy at foramen and extraforamen, because in stenosis cases, some ligament and some vascular dorsal ramus and vascular bundle is intermingled, and there's a lot of adhesion. That is difficulties. And proximity of working zone with exiting root and possible irritation of root. And estimating degree of superior articular process cutting between sufficient foraminal decompression and saving facet joint to maintain a segmental stability. And last one is assurance for symptomatic improvement, because sometimes we cannot assure a patient can improve only by the foraminal decompression. That is will be our last difficulties. Thank you for listening. Yes, please. You got a question? Please send him a mic.
Sorry, okay, it's late time, but okay. So you can do foraminal decompression, L4-5 level, very fantastic operation, okay. But how about L5S level foraminal stenosis? Is it possible or?
Yeah, L5S1 is possible, but L5 is a totally different story, because L5S1 is always difficult than any other levels. So if that is happened in L5S1 level, I will recommend the fusion.
Okay. And one more question is, sometimes when you're doing a foraminal approach with bipolar endoscopic surgery, and sometimes we encounter the serious bleeding problem from if you're going to the lateral side, okay? So do you have any tips? Maybe one portal endoscopic surgery, as far as I know, there's no serious bleeding problem, okay? So do you have some experience of bleeding problem?
Actually, no, because I start the operation from the lateral border of SAP. That is point of the artery and vein we can meet. So over there, I start operation and I identify the branch of artery and vein and coagulate first and then cut. With that maneuver, we can do operation without any serious bleeding. But in the old techniques, just go to foramen directly. It makes some bleeding over the facet joint. So I don't do that kind of old technique. I use new technique.
Thank you very much for your nice presentation again.
Thank you.
Dr. I have a comment about transforaminal. Yeah, I do paramedian PSLD. So it's the same as the foraminal decompression, but the docking point is in the anterior pedicle and the pars. So I go direct to the foramen. So it's easier that way, especially easy in L5S1 because it's accessible. If you go transforaminally, docking on the disc, maybe it's not possible.
Yeah, your docking point is SAP, or where do you dock in this case?
My docking point is, I use the hard landing. So my docking point is lateral border of SAP, not into the directed foramen. So when we see the lateral CM X-ray, I land before entry of foramen into the bone.
Yeah, and I also saw you used, was that a Kerrison which you used? You used a punch inside to remove the SAP?
Yes,
So what is the scope diameter which you are using for transforaminal? Scope diameter which you are using, internal diameter of the scope which you are using?
That is a transforaminal scope, but that is a new
4.1.
type.
4.1?
Maybe
working
6
channel, yeah, working
millimeter,
channel.
maybe 6 millimeter. The smaller one cannot, the punch cannot enter.
Yeah,
into
that's what, because we use a smaller one usually
Yes.
to take the benefit from the
Yes.
endosurgery. Yeah, okay, thank you.
And the punch is also very small punch, not a big one. So that scope is only for transforamen. So let me introduce next speaker, Dr. Siddharth Burma from India. His topic is PSLD contralateral approach for foraminal stenosis. Selvi, can I see your screen?
I'll just make it full screen. Now I think that.
Okay.
Yeah, so thank you very much. Thank you for inviting. I come from Mumbai, so greetings from my hospital, D.Y. Patil University, and this is in Mumbai. This is our fellows, our team, and my topic is very simple. Anybody knows this guy? Yeah, who is he? Dr. Adam? Kabi Lem, yes. So my presentation is very simple because this is like the third last presentation, and I think in all the cases all of you are potentially going to take the advantage of this contralateral decompression, and I'll be covering the indications, the technique, the experience, and some of the pitfalls. But for those of you who do not know about Kabi Lem, this is one of his video. Just have a look. No sound, no problem, no sound. I thought maybe after lunch most of you are sleeping, so another one. Then maybe one more. Oh, we have got sound. So I can go on and on with this, but you understand the point, right? So Yeah, maybe you can just go on and just go on Instagram or YouTube is very popular. So guys, this is about it. We keep the things simple. So the first two indications are very common, like foraminal pathology or bilateral pathology. But then with experience, most of us have learned that we also do it for if there is a vertebral rotation slide after UC, so that your trajectory is much better with the contralateral approach than with the direct one. And also if the width of the laminar space is narrow on one side and you want to go from the other side to kind of protect the structures and have an easier route. So I have made a change to this guy because I learned this from him. So this becomes this becomes very simple. So let's keep the thing simple. And so I'm using some of the published papers and I'm referenced it at the end, but I think most of you already know this. And in this case, as you can see, you have no much hypertrophy and you want to go through the straighter route. You don't want to manipulate much, so you can actually use this contralateral route. And the technique is already described today. Dr. Lim has already shown the technique for 2 times in the same patient, so I don't think I need to explain, but still you need to check the entry point with MRI and CT and estimate the trajectory and then put the dilator. If you are not going to resect the flavum, that is if you have a patient without hypertrophy, you can actually penetrate also. But if most of my patients need a resection, so I will resect it and then put in my endoscope and advance the scope with pivot sleeve between posterior dura and flavum. And this is how we do it. It's a bare area, no more advancing and more advancing to the lesion dural foramen, and check one AP picture. With experience, you will stop doing the AP check. Rather, it is just to show where you are, rather than you already know where you are once you identify the structure. This is a schematic diagram showing the same steps, and you can see this is a straight path to the pathology, and then you can go on from there. And at the same time, actually I reverse the same image so that it becomes more easy for you to appreciate. And so this is the first, the second and the third. So you can actually check this. This is the picture showing the ipsilateral and the contralateral one. This is the midline view with the axilla and the shoulder. You can see this everything here very clearly, and structures are not difficult to identify. One of the papers has even beautifully described it with the sublaminar, contralateral, interlaminar foraminotomy as the term which they have used. And so they created a sublaminar space. The steps are essentially the same, but for beginners this is a good reference point. They have even color coded the pedicles with a different color, and the flavum with a different this green color, and the lamina with a red color, so that you can actually kind of understand this better. So in my experience, it is very useful because of the large interlaminar space and large space between the dura and laminar arch in the midline. So I can even when I did my first case, it was not very difficult. Of course, I had one of my colleagues, Dr. Sai was there with me, so I didn't have any doubt about when I was doing my first case. Then take precautions to avoid neural structure damage, and the most common thing which I can think of is maybe my sleeve slips from the bone and goes on the cord. That's what scares me. So just keep a tab on your sleeve, and probably that would be good. And I often find that this is a super time saver actually, and it keeps things very simple. So this is one of my cases where I'm I've done with the procedure and just taking the check video, and just for Instagram. And so this is the edge. You can see the edge very clearly. Today also, once Dr. Lim was showing us, there were clots and other things, and he removed it. I am very cautious and careful as a relative beginner, so I don't remove anything. I am happy with the slight hazy picture, but I will not do the RF again. So I don't know, maybe with more time I can do it. So you can see that is the contralateral side now, and this is the midline, and you can see the other side also, which is there. You can see the root clearly. The axilla and the shoulder both are seen. So I think these are my references. A lot of papers. I think I took 2 of them from Dr. Lim himself, and then searched the literature and found some more literature which was not from him deliberately, so that I can see what others have also written about it. And I found that quite common things are there in between all the literature, so there was nothing which was contradictory. So thank you very much, and maybe see you sometime in Mumbai for one of our events there as well. Thank you.
Thank you for a good presentation. Any question from floor?
I think it was very clear. Keep it simple.
Yes, your presentation is very clear and simple.
Yes,
Thank you for a good presentation.
Thank you.
Thank you. Let's move. That is will be last presentation. Let me have Dr. Lamadasu Sridhar. Oh, it's not easy to pronounce. Sridhar.
Yes.
Okay, from India. Our last topic is stenoscopic lumbar decompression only in stable listhesis patient. A case scenario.
Good afternoon, everybody. I thank Dr. Lim and the conference organizers for providing me an opportunity to present the case. So, I'm an independent surgeon from India. Basically orthopedic practice for 8 years. I have done a very less number of open spine cases. I trained for posterior PSLD under Dr. Lim in the last July to October. So my experience is very less, maybe 25 cases. This is probably my 21st case. So Professor Lim is an opponent of, he doesn't want to fix the spine. So he always tries to minimize the instrumentation in the spine. So in this patient, I found a similar opportunity. So I do not know whether it is correct or not. I just wanted to present the findings. So my case is a 45-year-old female came to me with low back pain and bilateral lower limb radiation for maybe 6 months duration. Walking distance was 100 meters before the neurological claudication sets in. And VAS score was 8/10. So pain comes in the way of her daily activities. So she could not do her routine activities, and there are no comorbidities in the patient. So on examination, bilateral SLR was about 60 degrees. Power in the lower limb group of muscles was 5/5. So no motor deficits, no sensory deficits, with deep tendon reflexes being normal. Only pain was the predominant factor. So distal pulses was no vascular problems, so no upper limb involvement. So the radiology, she was an economically weaker section person, so she had a prior MRI. This is the MRI picture showing anterior listhesis of L3 over L4, grade 1 probably, with there is a ligamentum flavum hypertrophy, which is essentially pinching the spinal cord, compromising the spinal canal. So there was no evidence of any infection in the MRI. So this is the in the axial picture, L3-4, central stenosis with ligamentum flavum hypertrophy, and there is effusion in the facets. So doubtful instability. So I did not know whether to fix the patient or continue only with the decompression. So this is the flexion and extension view of the radiology of the lumbar spine in the lateral view. So in my books, if there is a 4 millimeter of translation in the anterior posterior plane, and if there is a angulation more than 10 degrees, only then we consider it as instability. Otherwise, subtle instabilities we can treat with decompression alone. So the plan was a standard posterior approach, landing of the spinal laminar junction, and resect the lamina to see the upper end of the flavum, ligamentum flavum. And this is the the surgery lasted about 56 minutes. During the clearance, so in the lateral side and the lateral recess, there was a small dural tear. So most of the ligamentum flavum I had removed. I just wanted to clear the lateral recess to see the lateral border of the dura. That is the removal of ligamentum flavum on the lateral contralateral aspect. One second, the dural tear is. So while taking the bite in the lateral recess, that was there was an adhesion between the ligamentum flavum and the spinal cord. So I took a bite of the lateral border of the thecal sac. So the tear was less than 1 centimeter. So I was afraid to continue with the surgery. So what I had essentially done was de-roofing of the canal at the level of the compression. I decided to withhold the surgery. I mean, after the ligamentum flavum was completely removed, so I did not venture further into it because I did not want the tear. I was scared of the problem of the dural tear. So I stopped the procedure after the ligamentum flavum of either sides were completed. So I wanted to take a chance. So I put the drain and I finished the procedure. The drain was kept for 2 days, 48 hours after surgery. Luckily, the patient did not have any complaints of CSF leakage. So less than 1 centimeter, there is no rootlet herniation. Only de-roofing of the canal done, and the tear was decided to treat conservatively. So my teacher, Dr. Lim, always insisted that you need not decompress everything. What you have to do is you have to make the space for the spinal canal, the spinal cord to move freely. So if there is a ligamentum flavum hypertrophy in the posterior aspect, so just de-roof the canal so that the spinal cord can actually accommodate in the newly formed canal. So that was attempted. So post-op X-ray, there was not much instability. Sorry for the poor quality of the film. So there was no much additional information other than that there is no additional instability that was created. I have not done resection of the bony facets that much. So post-operative, the patient reported improvement in symptoms on day 2 of mobilization. Drain was removed at 48 hours. So 6 weeks follow-up. She has, she mentions that she has got 90% relief in the pain, and she is hesitant to come to the follow-up. And I have requested for the MRI, but she is not getting the MRI done. So no resection of facets, no iatrogenic instability. So I believe decompression alone, just deroofing of the canal can be the first step in case of clinically stable listhesis, even when the MRI picture is very bad. Just always stick to the principles that if there is an X-ray that the flexion extension views doesn't indicate instability, that means that there is no angulation more than 10 degrees and there is no AP translation of 4 millimeters or less, you can still consider posterior decompression alone as a first procedure for stenotic patients. So deroofing of canal may be the effective procedure in case of clinically stable listhesis. Posterior stenoscopic lumbar decompression is a versatile tool for 21st century endoscopy, and majority of spinal fixations can be avoided. Apex of the spinal canal as a fat pad provides good confidence to open the flavum, safer in inexperienced hands. Some people here advocated lateral facetal entry. So I personally believe even in the later parts of the stenosis, there is a fat in the apex of the canal. So there is a triangular fat pad, so which actually allows the surgeon to enter the spinal canal without taking a bite of the dura, which sometimes occurs in the lateral canal. So I believe it is a safer entry. The spinal-lamellar junction is a safer entry for inexperienced hands. And don't be afraid of initial complications. I believe everybody can start doing PSLD. Thank you.
Thank you, doctor. Any questions from floor? Okay. Thank you so much, doctor. So now we closed our long session. No? Okay. Thank you so much. So I'm closing this session, and so we need to close our conference. Before that, I want to invite Dr. Lim to the stage. We need to get his final message.
Okay, today the conference was very wonderful. Thank you so much for the best snipers, speakers. So with the endoscope, you can do more meaningful work in spine field for the patient. So I will invite you the next the conference will be the October, New York, right? So we will organize Professor Kim and Dr. Datta and Dr. Ijam will organize a good endoscope surgery in USA, because there is no any endoscope surgery in USA. We all organize the first endoscope surgery conference in USA. I need your help, and I will give you some information about that. And then we'll organize the 5 cadaver, right? That's why I need your help. And the next year we will organize this Uzmiss again in Tashkent. It's very difficult to transfer here, right? Yeah. I think this conference could be the best, the wonderful, the endoscope conference in the world. We can make it, right? join us, please. Thank you so much. See you next year and October again. And thank you so much the Shatur Shomansuru and also Yakubok Akor also. Thank you so much.
Everyone still remaining here, please come forward to the stage. Let's take a photo.